Okay, I got lots of slides, so I'm going to start in. Here we go. Okay, starting again at that screening, brief intervention, and referral to treatment, we're going to go over how do you actually do that. So part of screening is taking a history. And so these slides are kind of geared to doctors, but, you know, I'm sure they'll be useful for who's ever interviewing people. And if not, at least you know what we do. So that single question, has alcohol or drugs ever caused a problem in your life, is the biggest bang for the buck. We were asking, you know, how do you help? Because you'll not only capture if someone's struggling now, if they struggled in the future, or if maybe they struggled due to a family member having trouble. And then you want to go through the substances. What type are they using, the amount, the route that they're taking their substance, which can impact on health effects, the frequency they're doing it, when their last use was, when their first use was, and screen them for if they have tolerance or withdrawal syndromes for each of the substances. And I'll go through what those are, because all of that will make a difference as to where you triage them in terms of treatment, what you need to do with them. Their detoxification and previous treatment history, and then, you know, you screen them with bigger tools, but that simple question around craving, loss of control, compulsivity, and use despite consequences, and you can phrase those in whatever way you think is acceptable to the patient. So where would you start? You want to be able to screen and assess and make a diagnosis. You can use paper and online tools. You want to do a physical exam, lab work, urine drug screen. We have Pharmanet. Do you guys have anything like that, where you know what's on? And you guys are welcome to all my slides, by the way. So anything that I have here, you can have. You can even have it in slide form if you want. You can give the talk again. I don't feel possessive at all. Knowledge, get it out, help others, yeah. So do you guys have Pharmanet or something like that? Some kind of medication? It's coming. Good, fantastic. Take a bow, who's ever in the room and having anything to do with that. So that's being able to monitor prescriptions. And so a doctor or pharmacist or someone in the hospital could look up what the patient's on so that we can see if other doctors have given stuff. And also if a patient's unconscious, or it's really good to know. And the pharmacist can then also know what drug interactions to look for. What is the patient's support setting? What's the patient's readiness for change? And if it's very low, perhaps a harm reduction approach is then needed. Acknowledge that drug use will continue, and that drug use may be the thing that is comforting them the most. That may be the thing that is helping them cope and stay in the game of life. So you do need to be careful. If you're going to take something away, you better build some skill sets. And look at ways to reduce the physical, mental, and societal harm related to the drug use for that person. And where do we start? So first, is the patient ready for an abstinence-based approach? Yes or no? Is there a withdrawal syndrome present? What risk factors may preclude outpatient detoxification for some substances? Like if they have suicidal ideation or they're psychotic, that's not a good outpatient management strategy to get in there, right? If they have really bad physical health problems, if they're prone to heart attacks and they're in a big arrhythmia, you don't want to be detoxing them from alcohol in the community when really they should have some monitoring around that. Or if they're homeless, it's hard to give a detox protocol for home when they don't have a home. And lack of responsible caregivers, especially women, are very influenced by people in their environment because they're more social creatures. And so it's really hard if you're trying to detox a woman if you send her home to a situation where her partner or family members continue to use. That's not a very realistic way to try to detox somebody. And if people are really heavy polysubstance users, sometimes trying to do one protocol for one substance in the community is not going to be effective because you really need to go at it all at once. So how to sort out if the person has a primary mental health issue versus a substance use disorder. Sorting this out can be quite tricky, and it's not always possible. One of the first techniques we use is a timeline. So were there any mental health symptoms prior to the initiation of the drug use? And during periods of prolonged abstinence, do they still have these problems? And under acute stress, do they have these problems? So for example, I'll get people in who say, oh yeah, I've always been depressed. And I said, yeah, but last year you said you were sober for a year from your alcohol. Were you depressed then? Oh no, I was working, I was feeling great. Oh, well, so maybe they don't, maybe it's the alcohol being the main driver for their mood disorder, not the mood disorder itself. Whereas you have other people who are, even before they ever started substances, had major mental health issues, and even when they're months or years sober, they still have extreme mental health issues. So you can help with a timeline. And also taking a family history can tell you that, first or second degree relatives with these same mental health issues especially. So again, with a focus on youth, there's many different screening tools. So I'm not going to go through all of them. I thought I would just show you the Craft. How many of you have seen the Craft before? Just a couple of you. So it's a great screening tool for youth. It's been validated. I'm going to ask you a few questions that I ask all my patients. Please be honest. I will keep your answers confidential. Confidentiality is super important for youth. During the past 12 months, did you ever smoke any hashish or marijuana? Yes or no? Use anything else to get high. And anything else can include illegal drugs, over-the-counter prescription drugs, anything that you sniff or huff or ingest or shoot, anything. If no, then we go to this other question on the next page, the CAR question, which we'll get to. And if it's yes to either anything in part A, we're going to ask all the questions in B, which is, do you ever drink any alcohol, anything more than a few sips? And don't count sips of alcohol taken during family religious events and things like that, but on your own. Have you ever ridden in a car driven by someone, including yourself, who was high, who had been taking alcohol or drugs? Do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? Do you ever use alcohol or drugs while you're by yourself or alone? And do you ever forget things you did while you were out using alcohol and drugs? And have you ever gotten into trouble while you're using alcohol and drugs? So this is very youth specific, hey? And if you're yes to any one of those, then it requires further assessment. And so for further assessment, you can then use this screening tool as an assessment tool by going into any of the ones that they said positive and just flushing out what's going on for them around each of those issues and helping to build a safety plan for that youth. The main thing is we want to keep them alive while they're experimenting or doing whatever, and help them toward less use or in a harm reduction approach, or to sobriety if we can. So expert screening, B, brief intervention. So brief interventions, expressing empathy and curiosity, stating your medical findings to someone can be very motivating. For an older person, let's say, we found that you have emphysema, your liver function tests are out, we found that you actually have hepatitis C now. These things can be incredibly motivating, but we have a treatment for that. We can help you. So people can learn. People get motivated to change when they get information about themselves that something might be going on, so they can alter their behavior around their addiction. But they also change not just through desperation, which is the classic, you must hit rock bottom, but they change through inspiration. Especially once the bottom's fallen out again and again and again in your life, you don't have much more desperation to get to. You're HIV positive and Hep C positive, you're on the street, you've lost 6 friends. What you want is something inspiring. If you come in and I can help treat that hepatitis C you have and help you not have withdrawal, and you'll feel a bit better. So you need to have the positive to help pull people forward. Educating around alcohol and drug dependence, giving advice, follow-up, and referring if necessary. Advice poorly placed at the wrong time, the wrong stage that the person, if they're not ready for that they can just rebel. But well-placed advice at the right stage where the person's at can be extremely effective. So I'm going to run through these detox protocols from caffeine, tobacco, alcohol, marijuana, stimulants, opioids. All right? So with caffeine, that includes coffee, black and green tea, chocolate, and cola. And I usually have to ask about all of those things. Also energy drinks, caffeine pills sometimes, depending on what the patient's using. And I keep a sheet in my office that has a list of about 50 different common items that people consume that are caffeinated. And so people can see how much caffeine's in each one of them. It's a typed sheet. Intoxication, 5 or more after having 2 or more cups of coffee. Restlessness, nervousness, excitement, insomnia, flushed face, diuresis, GI disturbance, muscle twitching, tachycardia, rambling thought and speech. I didn't have any caffeine today. Inexhaustibility, psychomotor agitation. It must cause stress or impairment, so that's just not normal excitation. And you have to rule out anxiety disorders, sleep disorders, and things like that, and other drug withdrawals. So that's the DSM criteria. Caffeine withdrawal can include headaches, irritability, and impatience, restlessness, sleep disturbance, slight dysphoria, and fatigue. And some people, even with 1 cup of coffee a day, will end up with the withdrawal syndrome. Anybody here can drink 1 or 2 cups of coffee a day, and then if they stop, have a headache? Yeah. So you in the room, including me, are slow metabolizers of caffeine. It means that we metabolize the half-life of the drug, which the time it takes to get half the drug out of your system, is more than 24 hours. Because if you dose on the half-life of the drug, you'd get steady state, but it's building up in your system enough so that you'd have a withdrawal syndrome the next day. And it's highly unpredictable. You have to do a genetic test to know who would be a rapid or a slow metabolizer. You know, some people who can drink like 6 cups of coffee and go right to bed like 2 hours later, right? These rapid metabolizers. And then there's the slow metabolizers who can only take a little bit and they get heart palpitations and blah, blah, blah. Yeah. So it's safe to tolerate to taper somebody at 1 cup every 1 to 2 days and things like that. It's not a problem. But why do we even ask about caffeine? I'll give you an example because most people don't even think about caffeine. And a lot of my patients, are drinking anywhere from 6 to 20 cups of coffee, and they're on all these sleeping meds, and it makes their withdrawal syndromes from other things a lot worse. And no one has ever asked them, but they put them on all these benzos at night to sleep, and but they're drinking 20 cups of coffee a day, and they never even thought about stopping. To you or I, you're like, you never thought about stopping 20 cups of coffee when you're waking up and you're peeing in the middle of the night and your leg is bouncing like that in front of me? I don't know about that. Anyway, so here was a patient I saw. She was a 37-year-old female police officer. She was like G.I. Jane. She taught the other police officers how to do SWAT team intervention. She was incredible. Right knee cartilage defect. She'd had 2 surgeries. She was on one of those continuous motion machines at home. On the couch. She was so bored. She was so pent up. So she's reading books, and she had surgery. She had chronic non-cancer pain in the knee. She was quite isolated. Her spouse was also an officer. She had a couple of kids who were gone at school during the day. And 6 months of this passive physio at home, just totally not her personality style. So they were giving her Tylenol 3s to try to cope with the pain, 1 to 2 every 4 hours, so 6 to 12 a day. Her anxiety was going up, panic attacks. She was having heart palpitations, insomnia. She felt she was going crazy, so they felt she was depressed. She must, her mood was dishing. So they gave her Duloxetine, which is a serotonin noradrenaline reuptake inhibitor. And then they gave her lorazepam, which is a benzodiazepine, like the Valium family of drugs, to calm her down because she's getting too stressed. So I saw her and I was like, what? And so I said, what are you drinking? And she said, you're sitting on the couch all day. You're used to being out. Are you drinking any caffeine? Yeah, 5 cups of coffee a day. Okay, what's in those cups of coffee? Well, each of them had 3 shots of espresso in them. Once I asked, she was like, what am I doing? Yeah, exactly. So if you add that with the caffeine that's in the Tylenol 3s, and then the 4 energy drinks she was pounding back a day, she was having 3,220 milligrams of caffeine per day. Oh my God. So caffeine can play a role when we're not even watching, not even thinking about it. So I say for her, you taper that down over about a week, and then you come off that benzodiazepine, and you come off the Duloxetine, and you get off that passive motion machine. You get into the swimming pool, because I know they don't want you to load your leg, but you're in the pool every day. Get pounding, get to work, soldier, Okay, so that's how you recover. So anyway, that's what we did. Taper her, change the Tylenol 3s, get her off all that stuff, and then get her re-engaged. Okay, good. Tobacco, a lot of you know a lot about tobacco. I won't linger here, but you know the withdrawal symptoms, which you can see there. And someone is likely physically dependent on tobacco if they smoke a pack a day or more, and within the first 5 minutes of waking up, they have to have their first cigarette. It's the most important. There's this grand detox, screening tool we use called the Fagerstrom scale of nicotine dependence. But the thing that is most important on that is, are you smoking a pack a day or more, and do you have a cigarette in the first 5 minutes? Because that means you're physically dependent. There's the habit part of the addiction, the physical act of doing it, And then there's the physiologic dependence on the nicotine. And if you can separate those two things out, the habit part and the physical dependence, you have a much better chance of treating smoking, tobacco addiction. So and I teach a whole thing on how to do tobacco. I used to run programs on tobacco dependence. But that's a whole nother talk unto itself. But just to know you can. So if you separate that habit part, in essence, you could do things like record your use and your behaviors associated with your use. And you can apply that to any substance. Let's say someone's coming in taking oxys and they're not ready to stop. Say, don't stop yet then. Why don't we just keep track for a week about when you use oxys and what you're feeling at the time? Just write down your behavior and what you feel. That's it. And your oxy. That's it. So anyway, so you can apply these kind of things to that. And then you can learn from there. So you record your use and behaviors. And then the second week they come in, let's say, you tell them, I want you to smoke the same amount of cigarettes, but just not at the same time that you did the day last week. So if you always smoke when you're on the telephone, we've learned from your record from last week, you can smoke, but just either before or after your phone call, not on your phone call. If you always smoke sitting in your favorite chair, you can smoke the same amount, but just not in your chair. And why are we doing that? Yeah, you break up the pattern. It's Pavlovian conditioning, when you get pleasure out of something and you associate it with something. So we're trying to break that patterning up before you actually have to give up the substance. You're going to be more successful if you can practice a different pattern before you actually have to give the substance up. The next week you might say, okay, now you have to, we're going to designate smoke-free areas. I want you to smoke still 1 pack a day, but I want you to instead, you have to go outside to smoke and you can't smoke in your car like you used to do. But I need you to still smoke a pack a day because I'm trying to not put you in withdrawal and sabotage you yet, but and get you going. And so you're building skill sets. And then the fourth week you say, okay, the thing that you identified to me that you got pleasure out of with smoking was, you wanted to relax, that's why you smoke. And the fear you had coming off of cigarettes was that you were going to gain weight. So if we can do a 2-4 and get you starting to exercise, you're going to reduce your stress and decrease your potential to gain weight here. So you have to know what the shadow side of the person's addiction is. You have to know the pleasure they get or the thing that they think they're getting out of the substance use and the fear or the negative thing they're going to have if they stop. That's the shadow side of the addiction. We usually ask the opposite. We ask, what's your benefit from coming off this thing? And what are your harms from using? But that who cares about that? I mean, let's talk about it because, that might help them affect change. But in terms of building a relapse prevention program, what you need to know is the shadow side of the addiction. You need to know what they're getting out of using and what bad thing can happen if they don't use. Let's use the example of a woman in an abusive relationship. What positive, we already know what the downside of being in an abusive relationship is and what the good side of leaving is. But let's do the other part of that 2x2 table. Let's say, what's her benefit from staying? Because a drug is like an abusive relationship. What's the benefit of staying in an abusive relationship? You have a home. You have a home. What could be, okay, and there could be like 40 things we can list, but what's one major downside of leaving that might happen? What's that?
I have nowhere to live.
I have nowhere to live. That's a pretty big downside. You don't get it if you just say, what's the upside of going and what's the downside of staying? So you really have to look at those. That's the driver of the addiction. The thing you're getting out of the drug use and the bad thing that might happen. Or some of my patients, he said he'd kill me if I leave. And if you don't ask that question, what's the worst thing that can happen if you stop using or you leave the person? They say he threatened to murder my children. That's a big thing. You're up against a big thing. So that's nothing to just go, oh, you should just leave. You should just go then. You better develop a really good strategy around that. That's a really good safety net. And like I've had to do, send police in and do a little SWAT team of my own with lots of social supports to get kids out of a train spotting situation. Okay. And then when you are going to start, you don't have to use drugs. You can just taper. So if you taper 1 cigarette every 1 to 2 days, it's really easy to come off. But the trick is with tapering, like with any drug tapering, but with tobacco particularly, is people try to stop smoking by going many, many hours without smoking, and then they'll have one cigarette, and then they end up having 6, and then they'll go many, many hours. And so that's not the way to stop. You want to keep your blood level even, so you still want to dose on the half-life of the substance. So with tobacco, you have to dose about every hour. You just smoke a little bit less of each cigarette. So for your first day, you might smoke 3/4 of a cigarette, and then a full cigarette and 3/4 of a cigarette, like that, every hour. And then the next day, you might just smoke 3/4 of a cigarette. Do that for a couple of days, every hour, and then bring it down to half a cigarette, etc. Do you understand? You tell the patient to keep smoking every hour, but just a bit less of the cigarette each day. And they'll come down a lot easier. Because what patients do is they try to hold off until they absolutely need it, and then their blood level is what? Super low, and they're in withdrawal. And so when they take their substance, what happens to their dopamine? And is that reinforcing? So you make it worse. You make it worse. So when you detox somebody, you have to know about that principle. And I know most of you know a lot about tobacco, but it's a principle that applies to a lot of other drugs. So I just thought I'd help you understand that. You have to detox people in a way that does not actually worsen their addiction. So there's patches you can use, and just some of the advice around that, they're available everywhere now, but we do still coach people around things like, you want to put it on furless skin, and you want to rotate it, and you want to make sure they're putting the right, furless skin, or it peels up, and you want to make sure that you're using the right strength patch, because it comes in like 21, 14, and 7, so they're labeled usually step 1, step 2, step 3 in the Nicoderm system. So sometimes people are just a 7 cigarette a day smoker, but they have to start with step 1, but they'll be puking, because they're getting too much nicotine. So it corresponds to 1 pack, 2/3 of a pack, and 1/3 of a pack approximately. So 21 milligram patch, 14 milligram patch, and 7 milligram patch. So you can choose accordingly. And the longer they can be on, the better. The studies are 12-week studies usually, but there was one year study. The longer somebody's patched, the better their outcome. Yeah, because you get over all that behavior, right? While you still have the nicotine on board. So, just patching somebody alone, you reduce their all-cause mortality by 50%. 50%. So, go ahead, patch. It's really good. But take your patch off if you get chest pain or lightheaded. A lot of patients don't know that because you put it over muscle. But if you work out or something, or run, or get in the sauna or hot tub, or sweat lodge with your patch, then you're going to suck off a lot more nicotine into your bloodstream, and you can get unwell and get chest pain. So just to be careful of stuff like that. It can give vivid dreaming if you're not used to getting up and smoking at night because you're getting nicotine at night. But a lot of my patients say they just dream in Technicolor, or it's just vivid. So I would phrase it vivid dreaming instead of nightmares. But if they are really disturbing dreams and they don't go away in a few nights, you can take it off at night and then put a new patch on in the morning each day. But you might need a little bit of gum to get your nicotine gum to boost your blood level up so you're not tempted to smoke. There's no evidence that e-cigarettes are necessarily any better than this, or that inhalers or other things, but you can use any nicotine delivery system you want. The only thing with the e-cigarettes is we don't know how safe, like strawberry inhalation taste stuff is and all that. There's no studies yet to show if that stuff's also carcinogenic or not. We don't know. So far, we think it's probably safer than all the garbage that goes into tobacco. And just to say, tobacco used in ritualistic circumstances episodically is not harmful, right? It can be used as a sacred thing. We have antidepressants we can use for nicotine, like bupropion. It's known as Wellbutrin. There's some dosing for you. It usually helps if you set a stop date. The 150 milligram per day can be as good as 300, and you can taper off after 3 months or stay on. Some people get kind of squirrely on the medicine. It does have an abuse potential. It's known as wellies in the prison system. You can grind it up and snort it and get quite a dopamine high, because it is a dopamine noradrenaline reuptake inhibitor. So there is street value for it. So do be a little bit cautious in that regard. But some patients really have a very positive response to come off tobacco. Partial agonist therapy, there's Varenicline, also known as Zyban. And it's shaped just like nicotine, and it binds to the nicotine receptor. It sits there, but it doesn't stimulate it as much as natural nicotine does. So it's kind of partial. It's a little bit like buprenorphine is for an opiate. So my tip with this, it's not on the product monograph, but just like in buprenorphine, you want to put somebody into withdrawal before you give it to them, before you give them Suboxone. If you do the same with Varenicline, you can have a little bit better result. So make sure the person's in withdrawal before you give it, because then if you're already in withdrawal and you take a partial agonist, something that partially stimulates your receptor, you'll go out of withdrawal a bit and feel good. But if you're loaded all the way up, I'm going to smoke 2 packs of cigarettes today just before I take my Varenicline, just before I stop, and then I take my Varenicline, and it'll knock all the natural stuff off the receptor, you'll go into withdrawal when you take it, and that'll feel nasty. And you can see our dosing, 0.5 milligrams for 3 days, and then you do it twice a day from then on, usually. Any questions about those 2 substances that are very common? Now we're going to go to alcohol. Okay. Am I putting you guys to sleep? Are you okay? Doing all right? Okay. All right, Canadian low-risk drinking guidelines. How many of you are familiar with that? Guidelines? Okay, about half of you. So it's 0 if it's contraindicated, and we'll go through some of those. Or 2 per, and you want 2 days off per week for sure. No drinking to let your liver recoup, and you're less likely to become physically dependent if you always make sure every week you have at least 2 days off alcohol. And the least harm done with alcohol would be then just 1 alcoholic beverage a day on up to 5 of the other days of the week. And that's what the Australian guidelines are. It's just 1 alcoholic beverage a day for 5 days a week. But the Canadian guidelines, they decided not to look at when harm was created only, but really they put their cutoff of when death rates start to rise. So if you look at death rates and not just domestic violence and everything else that harms, for females, it's less than or equal to 10 per week. So just 2 a day on those other 5 days, and for men, 3 a day on the other 5 days. And on rare events, if you're at a party, a max of 3 for women or a max of 4 in 24 hours for men, making sure that you pull back on the other days of the week. For those of you who are relative non-drinkers, that seems like an enormous amount of alcohol. For those of you who, have a good lifting arm, that might seem pretty moderate. But they set it so that it was a guideline to help curtail people who are getting out of control. If you're quite at risk of withdrawal if you're drinking more than 40 drinks a week, or if you're drinking more than, you're at risk for seizure if you drink more than 8 standard drinks a day. And just to note that 1 bottle of beer and 1 cooler equals 1 5-ounce glass of wine is 1 shot, 1.5 ounces of hard liquor. It all contains the same amount of alcohol. Whereas a lot of our clients, our customers, our patients, however you want to call them, don't understand that. So they think if I'm drinking beer, that's better than if I'm drinking whiskey. It's yes, if you're drinking the same amount, I would say yes, but it doesn't matter. You're still chugging back that same amount of alcohol, and it's having to be processed in your liver. And what happens, you suppress glutamate, your excitatory neurotransmitter, and your inhibitory neurotransmitter gets ramped up, and it activates your opiate center to give you dopamine release. It's really bizarre, but the pleasure you get from drinking is actually through stimulation of the opiate system. And then through that system, you get your rise in dopamine, and you get some serotonergic effect. And this withdrawal, so that you feel pretty good and relaxed, but it suppresses your excitatory neurotransmitter so that when you're in withdrawal, the opposite happens. You get too much excitatory neurotransmitter, and your inhibitory neurotransmitter is now suppressed. So, you start to flap and shake, and everything, you're overexcited in every possible way. And tremor is the best predictor of a seizure. So in withdrawal, 2 or more of the features that you see there, autonomic hyperactivity, heart rate, sweating, tremor, insomnia, nausea and vomiting, anxiety, hallucinations, illusions, psychomotor agitation, and grand mal seizures. Both use and withdrawal is problematic, and it's metabolized by alcohol dehydrogenase, into acetaldehyde, which is the thing that makes you flush and vomit and feel sick. And from there, it goes via acetaldehyde dehydrogenase into acetate, which is vinegar. So you do actually get pickled when you drink too much. You produce vinegar. Yeah. So how do you lower, this is an alcohol lowering strategy. So the person's not ready to stop, or they're not, you're not recommending stopping. They're in a range where they might be starting to get problematic. Keeping a drinking diary, same kind of principle as we did with the tobacco, sipping and spreading your drinks out every hour. These kind of things seem a little bit boring compared to sexy, medications we can give and protocols, but they're actually more important on day-to-day life. Practice refusing drinks. Refuse every other drink. Okay, you can go to the party, but just refuse every other drink you're offered. Just practice that. Measure your own drinks. That's really important for women, especially at parties, so they're not given stuff that will either load them or stuff isn't added to their drinks. Eat food and rehydrate prior to going. So if you drink 8 ounces, 12 ounces, 16 ounces of water before you go to a party, and you have a meal before you go to a party, you're less likely to binge on alcohol. And then social functions: arrive late, leave early, and increase other activities and interests. A lot of people who get really into drinking and drugging don't have a lot of other interests that don't involve drinking and drugging. So they've gotten so they can't even list things they can do that don't involve drinking and drugging. So how do we taper? You can taper by 1 to 2 drinks safely. People are unlikely to have a seizure if they taper by that amount. If they're drinking less than 7 drinks a day, they usually can stop cold turkey unless they've had a seizure disorder, delirium tremens, or a head injury previously. And we do offer residential detox or hospitalization if they have a history of over 8 drinks a day, less if it's a significant head injury, if they've had seizure disorder, alcohol withdrawal, seizures, DTs, suicide attempts, psychosis, violence and withdrawal, if they're pregnant, have cardiac or medication issues that, or medical issues that are important in that way, or super socially unstable. So it's a lot of people who might need residential detox. And the classic detoxification protocols really have come down to the CWA-AR protocol. Any of you use those in the hospital here, CWA protocol for alcohol withdrawal? Yeah, so that's kind of the classic one. There are some other protocols that have been coming out lately, but this is the granddaddy gold standard developed in Canada at what was the Addiction Research Foundation in Toronto, and showed that also the use of beta blockers, neuroleptics, anti-epileptics as monotherapy are not as powerful, unless some other data I'm going to show you soon. So this is a basic CWA protocol. It's a nurse-driven protocol where they score them on all these different things: how shaky they are, if they feel bugs crawling on their skin, how sweaty they are, if they're anxious, all sorts of things. And if you score a 10 or above, you get medication. So either diazepam or lorazepam, you can see here. Diazepam 20 milligrams every 1 to 2 hours until you bring your score down and you keep observing them, or lorazepam 1 to 2 milligrams every 2 to 4 hours, or if they're young, we can use 2 to 4 milligrams. Thiamine, we used to only give 100 milligrams intramuscularly. It's a B vitamin that will block some of the withdrawal effect that can lead to brain damage, because if your glutamate is slamming out too fast, you can actually damage parts of your brain when you're in alcohol withdrawal, and the thiamine, the B vitamin, will help. But now we give a much higher dose of thiamine. And there's also a barbiturate protocol. So I just included that here. I'm not going to go over it in too much detail for those of you who don't do detoxification protocols, but I'll give it to Sharon, so, for distribution, Sharon and Stephanie and Aaron. So there are phenobarb protocols, the bottom line being that you can phenobarb load the person, and I included a protocol here. It's 120 milligrams every hour, but they can get really emotionally labile, and I gave a example of one of my patients who jumped out of a window after but the security guard caught him by the ankle, because you get really disinhibited. But if someone is on benzos and alcohol, and so you can't use a benzo, sometimes you have to do that. And then in the office, you can ensure the patient's physically dependent, and if they're drinking more than 6 to 8, you can benzo load them. They have to have somebody safe at home, and they can't just have ingested alcohol and you give them a benzo, you can kill them with that. But there's a schedule here. There's a fixed dose schedule. You give 20 milligrams every 1 to 2 hours for 3 doses. And then or you can use lorazepam. Or there's another way to do it where you give 10 milligrams every 6 hours for 4 doses, then 5 milligrams every 6 hours for 8 doses. But you have to watch them and have somebody reliable around. We're also using anticonvulsants. There's some evidence around the use of anticonvulsants. So if they haven't had a seizure or head injury before, instead of using diazepam, which is also very divertible, you can use gabapentin, which does also have a street value, and people use it for intoxication a bit, unfortunately, but it is a bit safer. So there's a little protocol here you can use. What you do up to 1200 on days 1 to 3, then you can see how it tapers down. And this can be very, very good, and the patients usually feel a lot more even on it, not so anxious in withdrawal, and you're not worried about them dying so much of an overdose with combining alcohol and benzos if they slip. So ideally, you'd want to see the patient as daily or close to daily as you can while you're doing that. And if they fail 1 or 2 outpatient, then bring them into inpatient detox. And then I'm going to go through, I'm not going to talk about these because only if you're prescribing does it matter too much. But just to know that there is, Antabuse is Disulfiram, so that's aversion therapy. It makes you sick if you drink. It blocks that second enzyme of breakdown of alcohol, your acetaldehyde dehydrogenase, so it builds up acetaldehyde so you feel sick and flushed and cough and want to throw up and all that. But you feel lousy. Naltrexone is an opiate blocker that we use long-term for people who are on trying to stay sober from alcohol, and it decrease the pleasure from drinking and help to reinforce abstinence, especially if you use the injectable form. And acamprosate also can help. It's Camprol. Do you guys use any of these medicines? Are they authorized for use here in the... Yeah, so I'm getting a nod. Yeah, so it's also used for alcohol. It increases your GABA and decreases your glutamate, so it helps you with some of the withdrawal symptoms. It's just a big pill burden. You have to take 2 tablets 3 times a day. And then gabapentin, again, is easier to use, I would say. And the benzodiazepine family, again, if you can see neurological symptoms, blurred vision, depersonalization, and shakiness, warn them that these things can happen. And you don't want to stop abruptly diazepam that's over 50 milligrams a day. You want to taper. We can convert to a long-acting benzodiazepine, the Valium family of drugs, and taper. So usually you'd give 75% of the long-act, 50 to 75%, and then add in the short-acting. And I'm going to show you a more complicated way to do that. People don't have perfect cross-tolerance between the different benzodiazepines in this family, so sometimes we just need to go slowly. So here's an equivalency table, and this would be an example. Someone who's on lorazepam 3 milligrams a day. First you'd spread it out to 1 milligram 3 times a day, and then you start adding, because lorazepam's short-acting, you want to add in a long-acting instead. You want to convert them over. So someone who's highly sensitive and you just can't seem to get anywhere with tapering the lorazepam, put them over onto diazepam and take them down. This is the Ashton protocol. I think it's way too much hand-holding. I can convert people a lot faster usually, but if for people who are highly sensitive and you can't get anywhere with them, just try this. So you add in just 5 milligrams of diazepam, take their lorazepam down by 0.5, and you keep substituting in doses, you can see, where you give diazepam and take away a bit of the lorazepam. And you do that over days until they're just on diazepam, and then you start tapering super slowly the diazepam. So you can see that this is... This can take many, 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 many weeks to do that, to get them right down and off. But for a highly sensitive patient, you might need to do that. So marijuana, there's really nothing we can do medication-wise aside from treat some of the symptoms, the sleep disorders and some of the anxiety as people come down, but not for the substance use itself. There is synthetic cannabinoid spice. Do you guys get that up here? Anybody get? Incredibly powerful. People get really psychotic on it. They're nasty to deal with, but they don't show up on a urine drug screen. So in like the oil fields and stuff, a lot of guys use them. You may have it up here and not know it. Okay, Phoenix tears is really concentrated marijuana, THC, but spice is synthetic. Yeah. And why marijuana works at all is because our brains make an anandamide. We make a substance that binds to CB1 and CB2 receptors. They named it anandamide because ananda is from the Sanskrit, from the god of bliss, Ananda. They're highest at the point of when you deliver and when you breastfeed. So you bond. It's a bonding chemical. So you can see how the kids bond with their peers when they're using, and they don't want to talk to their teachers and their parents. They just get all bonded. It's as if they're like nursing together. There you are, off their joints. Here, have this. Oh yeah, nice. Yeah. And it creates false novelty. So when you're together, everything seems new and interesting, even though you've been doing the same guitar riff for 45 minutes. Whereas the next day, you feel flat, and you're like, I don't care about world history and events. I don't, that's not interesting. But, hearing that same song that you sang to me over 25 times, I'm crying again because it's so interesting. Yeah. Withdrawal symptoms, you guys are probably pretty familiar with. The main thing that people don't understand is one of the main withdrawal symptoms is people get anxious and they get dysphoric. And so then to treat their withdrawal, they use, and then they end up thinking they need marijuana for a medical reason. They think they have anxiety and depression, when really it's a withdrawal syndrome. But it can take 3 to 4 months to wash that out, or longer with marijuana, right? Because it fat stores if you're using it every day. So unlike other things where you usually get a response a lot earlier, often it takes a long time to get a good response. And especially youth, they're like, no way, I feel better when I use. Well, yeah, you feel better, An alcoholic feels better when he uses too, But that doesn't mean that is the appropriate treatment for your particular disorder. And if you do have an anxiety disorder, there's evidence that it may actually worsen PTSD, not help, unlike what the military seems to be doing. Yeah. It stimulates appetite. So in withdrawal, everything is the opposite. So it's not anorexia nervosa. It's just that you just aren't hungry. You feel you don't feel like doing anything. Yeah. Okay, good question. I'm going to skip that. And just to say, there is a genetic component. If you're valine positive, that COMT allele, you have a lot higher chance of getting psychotic than if you're methionine positive. So we'll be able to do a buccal swab one, and just say, oh, you shouldn't be using that. That's not your drug of choice. The big thing I want you to know about cannabis is that there's two things. There's lots of cannabinoids, over 70 cannabinoids, over 400 chemicals the plant makes. But the two main ones that we need to know about, THC and CBD. THC is what produces the high, makes you dependent, and is what a lot of people find is pleasurable. But it also is the thing that makes you psychotic, makes you hallucinate. The higher the potency of THC, the more likely it is that you will hallucinate no matter what your genetic background is. So we want lower. When I was in high school, it was 3% THC. Now what happens is the THC has gone up and up, which I will show you. Woo, woo, woo. Yeah, exactly. THC is going way up to, in BC, the stuff you can buy is up to about 45% THC. And marijuana isn't just leaf anymore, right? We have leaves, and then you can do something to them to get them, boil them down and extract to get oil. And then if you take the liquid component out of the oil, you get you get butter, it's thicker. And then if you keep going, you get crumble. And if you keep going, you get a brittle substance called shatter. And that's up to 95% THC. So again, we're talking the difference between chewing on a cocoa leaf and doing crack cocaine, smoking the weed that was available when I was in high school, and what the kids are exposed to now, because cannabis is no longer just a little leafy thing that grows in the, in the back garden somewhere hidden. It's something that is a highly concentrated thing that kids are sucking on in their little e-cigarette pipes and stuff, in their vaporizers all over the place. So, and the other thing the plant makes is CBD, and it can't make both THC and CBD effectively at the same time unless you've produced a very hybridized plant. And so usually if it's high THC, it's low CBD. As you can see on the example on the left, 21% THC, CBD is 0.15. And the indica strain is 16% CBD and 0% THC. So it used to be we could say just use indica strains because you want the CBD is actually anti-inflammatory, maybe neuroprotective. That's the thing that they're trying to look at. Does it help with seizures in kids? And it doesn't make you addicted, and it doesn't produce psychosis. So it's basically what hemp plants make is CBD. So that's a joint, not that. But that is what kids are using if you put it down into shatter, right? It doesn't look that big. It's just a small thing. We recommend vaporizers and not mixing. And the whole edible thing, basically, there's a study done, and even looking at mislabeling of edibles, this is only 17% of edibles in this study, looking all the way from California up through Washington, where they collected 75 products in dispensaries, were labeled even within 20% of what it said. So you don't know what THC and CBD are really in a product, even when it's labeled. Patients shouldn't drive within 4 hours of inhalation, 6 hours of oral ingestion, and 8 hours after inhalation or oral ingestion if they get euphoric, and there's no clear medical treatment. It takes weeks to wash out to get your IQ back to baseline. It can drop your IQ 6 to 9 points. If you were an adult when you started and you weren't a daily user, usually that will recover. But if you were a daily user before the age of about 13, it's you don't usually recover. It can you can stop abruptly, but might need to manage the mood drop and the insomnia. So in the last 5 minutes or 3 minutes or whatever I'm supposed to have, we'll do opioids. Yeah. Yeah, so it's a natural derivative of poppy plants, and then there's synthetics that we make, and it binds to different receptors, opiate receptors. It can relieve pain and give you pleasure like we talked about, but it also suppresses adrenaline, this noradrenaline, and it affects your brainstem, so you can overdose if you have too much because it makes you stop breathing. It suppresses your brainstem. And that's classic intoxication, constricted pupils, and nausea, vomiting, coma, and death. And this is kind of the reason that some of the summit was called, is this kind of thing. This mom put this on her webpage and asked that people share just a few weeks ago. This young man, Michael, who is an episodic cocaine user, got something cut with fentanyl and overdosed and died. And this is his mom, Sherry, in the ICU, curled up with him just before they pull the tubes out, and he dies. So she posted, I just want everybody to know that my son Michael overdosed on fentanyl, and he was not an addict. He made a mistake that cost him his life. I just want to make everybody aware that the epidemic's going right now that's killing 5 to 7 people a day in Canada. It's out of control, and there's no way to protect our children. There is some, but, and she's lost her son to this horrible tragedy. And it's the #1 killer taking our kids. It's now surpassed motor vehicle accidents in terms of death rate. And so we want to try to help prevent. And classic opiate withdrawal is one of the things that drives. Okay, we'll finish the opiate section. I've been giving a pass, that's good. So if you have 3 or more within minutes of stopping, you feel dysphoric, which is like low mood, nausea and vomiting, muscle aches and pains, and that can really be a driver. I'm going to talk about that tonight. The pain of withdrawal can really be a driver. And a lot of people confuse that for chronic pain. A lot of people think they have a pain disorder when they just have a withdrawal disorder. Runny nose or eyes, diarrhea, yawning, fever, insomnia, and pupil dilation, sweating, that kind of thing. And so to manage that, to withdraw from legally obtained drugs, you can leave the person on a short-acting medication and taper from there, or you can convert them to a long-acting by giving them the same drug minus about 25% and add back in a long-acting, like you did with the benzodiazepine taper schedule. You just take away a little bit of the short and give them a little bit of long over a number of days until they get that conversion. And then you taper them by 5 to 10% every 1 to 2 weeks. And if they can't cope with that, do it 5% drop every 1 to 2 months. If this is a legal drug that you've been prescribing for chronic pain or something. Taper them faster if they're inpatient or if they've only been on for a brief time. Now, what if it's an illicitly obtained drug that you haven't been prescribing, so you can't just prescribe them more drugs like this? You can bring them back with I'm going to show you a Clonidine protocol. If it's someone you won't prescribe an opiate to, or it's inappropriate, or they've forged all your previous prescriptions or something like that. This is a Clonidine protocol. No caffeine, mild food, minimal exercise. You don't want them to go into the sauna with this protocol. A caregiver needs to accompany them, and a pharmacist can dispense their medication daily. Or if they're in residential care, we can use a CNA protocol to determine how much they need. It's like the CWA protocol only for using clonidine in opiate withdrawal, but you don't need to use it as an outpatient, but if they're inpatient, you can use it. The clonidine, you would give, clonidine is a blood pressure medication, but it blocks the adrenaline component of opiate withdrawal. So it makes you feel calmer, you don't get hot and cold flashes, and there's some evidence now that it can block pain as well. So it's 0.1 milligram 4 times a day for 4 days, and then 3 times a day, twice a day, once a day. I give them a test dose because it can dish your blood pressure. If they don't drop their blood pressure, they're good. They're good to go home with that medicine. And there you go. We can double that dose if they're inpatient. And then along with that, we would give gabapentin at the doses you see here to help with anxiety, insomnia, and pain. We used to traditionally give what's down below here, diazepam at the bottom, but that's really abusable. So only in an inpatient setting, if the other doesn't work, would I use that. And quetiapine is also a drug we can use. It's an antipsychotic drug for sleep. Trazodone works really well for sleep in this setting. And loperamide is for loose stool. It's Imodium, but it is an opiate itself. It is abusable, so you have to be careful you're not giving it to people to run with. Dimenhydrinate for Gravol for nausea and vomiting, ibuprofen and acetaminophen. So this kind of outpatient management or inpatient management if you can't give an opiate for some reason. But these don't work nearly as well as using methadone or Suboxone to help somebody come off. So a kind of methadone treatment schedule, it is an opiate, it's a synthetic opiate. Usually we want to use it for people who are very established users, in their 20s, or beyond, not teenagers if we can avoid it, or people who are HIV positive or injection drug users who have tried other things and want this. It's a very long half-life, 24 to 36 hours, but it does help reduce drug use and all the things you see on the sheet there. This is how we use it for detoxification. If people don't want to be on opiates at all and they just want to detox, we'll give them up to about 30 milligrams in one day and just taper by 5 a day, right? But if they're already on methadone, you never do that fast a taper. That would they couldn't go from 100 milligrams, they come into a treatment center, we're just going to go 30, 25. No. It's way too fast. So Boson Nodik did a study where he looked at people who are already on methadone, what's successful to come off. And only 4.4% of people who are on methadone can get off successfully at 1 year. It's a hard drug to get off of. Now, part of it is the population is always relapsing anyway, but it's a really hard drug to get off of. And if you're going to taper, this is the way to do it. You see the 2 boxes that I've checked in the upper right and lower left? These are slow tapers over up to 100 weeks. Super slow in little steps. So you might go down and every 2 to 4 weeks make a 5 milligram drop. And some months you might hold for a month or 2. What doesn't work is to rip them down fast or to jigsaw, to go up and down and up and down and up and down on the dose every time the patient comes in. I want more, I want less, I want more, I want less. That does not work well. So he did this analysis of all the people in British Columbia who'd come off over a couple of years to get this data. So I think that's very valuable. Buprenorphine in Canada, we have both the patches and the tablet form in the form of Suboxone. The patch is the Butrans patch, and then the Suboxone comes in 2 and 8 milligrams that you can see there. And it's a partial agonist, so like the Varenicline we talked about with tobacco, this binds to the opiate receptor partially and stimulates it a bit, but blocks the other opiates from getting in to some degree and can knock other ones off the receptor. The other thing is it hits a very different receptor, the kappa receptor, and it blocks the kappa receptor. And that actually can lift your mood. So it's used as an antidepressant in Europe. It's as good as an SSRI, a serotonin reuptake inhibitor. So this is the deal with Suboxone. Like with fentanyl, do I have to do this? If you can, are we good? Thanks. If you can see the upper curve, with fentanyl, you go up into the high zone where you'd overdose. So the dotted line is apneic where you overdose, the top red dotted line. And so with fentanyl or other opiates, you just sail off into that if you just keep taking more and more. Whereas you get this ceiling effect with buprenorphine, which is the blue one, which is what the trade name Suboxone is. And so even if you keep taking more and more and more of it, you don't overdose. So that's the trick. It doesn't affect the brainstem in the same way, unlike any other opiate. It's the only opiate that has a ceiling effect. If you take it with a benzodiazepine, the Valium family of drugs that's in that family, you will lose that effect. And you'll turn that right into like the other drugs, and you can overdose on it. So there's been only a handful of deaths on Suboxone, and they've all combined with benzodiazepines. So that's about the ceiling effect with respiratory depression. And we want to convert from other opiates into buprenorphine for detoxification or maintenance, and no longer we don't need methadone exemption and added training. And if you convert from opiates into buprenorphine for detox for pain patients, that's off-label in Canada. Right now, you're not supposed to, it's not authorized to prescribe for pain, but it's used by many doctors in the US and Canada, and in Europe it's used. So it's we think it's much safer, and so we're now encouraging people to use Suboxone and buprenorphine in the patch form instead of going to other opiates. So if you do need more acute management, you could use a Butrans patch, for example, 5 microgram per hour patch, and they're not going to overdose, and the addiction liability is much lower with buprenorphine. It decreases overdoses, it discourages diversion, because in the Suboxone form it's mixed with naloxone that if you take orally doesn't have any effect, but if you inject it you get precipitated withdrawal. So it shoves you into withdrawal like Narcan, like the naloxone injection kit. And then it helps with depression. So a lot of patients do extremely well. How many have had a patient do well on buprenorphine in this room? A few. Yeah. So the downside is you have to ensure the patient's in rip-roaring withdrawal before you start it, because if they're not in withdrawal, you take the Suboxone, it's going to push everything else off the receptor, and you're going to go into withdrawal and feel sick. It's called precipitated withdrawal. So we get them into good withdrawal, and then we start low, give 2 milligrams, 4 milligrams, 6 milligrams slowly throughout the day. If you want to know how to do that, there's a training course coming out through the BC Centre of Substance Use, and Sharon can help with that, and they may be bringing people here to help train. But there's an online course to do, and I'm going to be adding a pain component to that online course through our center. But there's some easier ways to do that, so I'll teach you some tricks. The problem is that if you just put people on and taper them off in 2 weeks for adults, or even 12 weeks, they go back to use. If you don't give them any other social supports and they're not in some kind of wraparound integrated plan, you can add counseling just for a few weeks, but it doesn't make a difference because it's a long problem. That's why maintenance therapy usually helps, and only taking away the drug once people have actually got some stability. So I really like the high school program that May was talking about, where they really decide when to take the person off according to how stable they are, the youth off. So some only needed 3 months, some needed 2 years. So that's much more realistic, depending on background. Because buprenorphine has a ceiling effect for overdose, and it's been viewed as a partial agonist, people thought it was only partially effective for pain. But that's not the case. It's as good as morphine or other opiates for pain. And there's a great review of that was just done in 2014 that showed 24 controlled clinical trials identified, plus a case report and dose response curve based on complete or comparable pain relief in buprenorphine, had full clinical analgesic effect in 25 of 26 studies. And if we look at converting people who are on other high-dose opioids, and Deitch did a study in 2014, where he took people who are they had to be on over 200 milligram equivalent of morphine up to over 1,000 milligrams of morphine for pain, and they converted them to Suboxone, and their pre-pain average scores were 8 out of 10 and went down to 4 out of 10 post-conversion. It's really good for pain. So if you can see, the patient was on anywhere from 200 to 400 milligram equivalent of morphine, so it might have been oxys or fentanyl or whatever, but it would equal that much morphine, or 4 to 1,000 or over 1,000. And I'll tell you, our new guidelines are you shouldn't go above about 80 or 90 milligrams. So these are high-dose patients, high-dose patients, their pain drops 50% in whatever category if you put them on Suboxone. So it's a really good for pain. And so how do you put them over? I've given some scoring here. The Butrans patch, a 5 microgram patch, is 20 milligrams of morphine, 10 is 40, 20 is 80. So if they're on another opiate between 80 and 100 milligrams, you can just use one of these patches and just start with a 5 milligram patch, add a little bit in, and remove 20 milligrams of their morphine equivalent, and so on, and add it back in. Change every 7 days, increase the patch until they're switched over. If they're on for addiction, or they're on much higher doses, then you have to use Suboxone, and we'll do that and then we'll be done. So you want to ask the patient to return all their patches and keep them in a safe, and their patch, if they're on a patch, it's not going to show up in a urine drug screen because it's picograms that come out. It's such a tiny dose. If you want to put them on higher strength because they're addicted to an opiate like oxycodone and you want to get them over onto Suboxone, you have to be careful about that switch, or they can go into fast withdrawal, and if you overstimulate the kappa receptor, they'll get kicky legs and very anxious. So the classic induction strategy is getting them off for 12 to 72 hours and having a COWS score, or this withdrawal scale, 13 or higher, and then giving them 1 to 2 milligrams every 2 to 4 hours until they're between 8 and 12 milligrams. And then on the next day, give them the first day dose plus 2 milligrams every 4 hours up to 16 milligrams. And then the third day, the same, up to 24 milligrams, and not to go above. Do you guys have a limit how high you can prescribe here? Can you go to 24 or just 16? Or? Yeah, with race consultation. Yeah, so it's rare that we ever need to go to 24. Yeah. And if used just for chronic non-cancer pain, you may need to be under 2 milligrams even, because it's so strong, right? It's just a tiny dose. And you may need to split it. If it's for pain, I always just start with the patches. And you might need to split it 2 or 3 times a day. If it's used for maintenance, you can adjust that. And if you want to come off, just taper off very slowly. And at the bottom of your taper, use your Butrans patch again. You can bring them down with a patch, a 10 or 20 microgram patch, leave it on for a week, and then bring them down. But some of the tricks with this is you can use the patch as a bridge. So let's say they're on oxycodone for chronic non-cancer pain and you want to give them on Suboxone, but you don't want to put them in withdrawal for a day or two. They can't do it. They just can't get there. Then you can put a buprenorphine patch on them the last day they have their medication, and it will slowly rise overnight, and then you start the Suboxone the next day, you get almost no precipitated withdrawal. So you can do that in detox centers if they're coming off heroin or oxy or whatever, or fentanyl. You can do that in the hospital. You can do that as outpatients, whether for pain or for addiction. So we use these bridges. We use a bridge. Typical 12 to 48 hour abstinence is a barrier. So if they're on long acting, switch them over to short acting and then start the buprenorphine patch. We use a Butrans patch, 20 micrograms. Within hours of stopping their short acting, and the next day you do your induction. Lickety split. There's also, if you don't have Butrans patches because it's not covered, because in BC it's not covered on the pharmacare, so instead we use what's called you can use the Bernese Method, where you take the Suboxone pill itself and just scrape off a bit of it, give them like the 2 milligram tablet, give them a quarter or less than an eighth of the 2 milligram tablet, and add in a little bit and overlap it with the other one. So here's a case of a 30-year-old woman who was sniffing 3 grams of heroin a day, and every time she tried to get over, she had too much precipitated withdrawal. She couldn't get through the days without using in order to get onto Suboxone. So they did a Bernese Method. I'll show you. So on the day 1, they gave her 0.2 milligrams of Suboxone and 2.5 grams of heroin she contracted to use on the street, and then 0.2 of the buprenorphine. You can see how she tapered herself off the heroin as they slowly increased her buprenorphine. So you can do it without a patch is what I'm saying. And the last thing about buprenorphine is we used to think we had to take people off Suboxone when they went for surgery so we could control their pain with a proper pain medicine like morphine or fentanyl in hospital, but we now know that that's not true at all. We need to leave them on their Suboxone usually and add on top of that either hydromorphone or fentanyl for some pain relief. So, or even for some people, even morphine. You use up less opiates overall. If you take them off their Suboxone, they end up opiate deplete, and it's really takes days and days to catch up. So this study showed that you end up using much more opiate overall if you try to take people off, and they end up with longer lengths of stay. So just add on top. Okay. And naloxone take-home kits. Do you guys have those up here? Yeah. And so the long-acting form of naloxone is called naltrexone. It's a once-a-day formulation. Anybody use that here yet? 50 milligrams. It's a tablet once a day. It acts like body armor. It'll repel half to a full gram of heroin. It's also used for alcohol use disorder under the trade name Revia. It's great, and we don't hear it in the media. It's fantastic. The thing is that if you go off of it, your receptors are all cleaned off and you have a higher chance of overdose. So that's why there's caution with use. It's good if you can witness the person taking it every day. If you're with their parent, you'd want to put that in their face every day so that they're not overdosing, right? Even better is the injectable form. It's called Vivitrol in the United States. And we don't have it here, but the Canadian government will allow you to do it on special authority if you apply straight to the feds. You can get Vivitrol. You have to import it, but it's super expensive. It's $1,200 a month to $1,400 a month. But daily heroin is a lot more expensive, a couple $100 a day. And, $1,400 a month. I think, I worked the mobile medical unit in the downtown east side for the 4 months it was open. And, I'd see kids that I'd resuscitated 6 times over the last, several weeks. And you think, it's a lot cheaper. And they wanted treatment. There are no beds. They want treatment. They're fed up. They've tried Suboxone and Methadone. It wasn't working for them. They want a sober treatment option. They want out of the cycle. But I didn't have the drug to give to him. In the United States, the 4 drugs that are authorized for opiate use disorder are Methadone, Suboxone, oral naltrexone, and injectable naltrexone. It's available everywhere. But the company that makes it there, the market share is not very big in Canada, so they haven't bothered paying the $1 million it takes to enter a Health Canada application to get the injectable in Canada, and they'd have to market it all over Canada. We're too big a country. It would cost them too much money. They're making too much there, and they're a small company. Why should they bother? So we need to advocate for that. That's something that you guys can do here because you're small. You could advocate and bring in injectable naltrexone for your population, which would treat your alcohol use disorder and your opiate use disorder. It's like there's the latest study on naltrexone. It was in a population that was dealing with in the criminal justice system. They were out on parole and could voluntarily, through their medical doctor, choose if they wanted to have naltrexone, the blocker, or go on Methadone or Suboxone, or just have counseling, or just be free, and they could choose. The ones who chose to try to come into the study got randomized to the naltrexone or one of these other treatments as usual. There were over 100 patients, 150 patients about in each group, and they followed them for 2 years. And there were 7 overdoses in the group that had treatment as usual, and there were 0 overdoses in the naltrexone group, even though they only gave naltrexone for the first 6 months. It's highly protective. So if you're looking especially at youth who keep overdosing, if you can afford it, if it was my kid, I'd be wanting them to have injected naltrexone if possible. There are some complications with it, but it's a blocker. Yeah.
You're starting for naltrexone 2 weeks after last use. What's the reasons for the titration up? Why can't you just start it?
Okay. So what I do is I always start oral naltrexone first to make sure they don't have a reaction. Because someone might say to you, like some of my patients, I don't know if you have this ever happen to you, oh, I haven't used in 2 weeks. And I give them a little bit, I give them a tiny dose, a quarter of a tablet. And then they're like, blah, blah, within 10 minutes, they're barfing, they're hurling. I'm like, okay, that's okay. Well, it was just once. It was just one. Yeah, I know. It's like a truth serum. Yeah. So don't, and I said, you can just lick the tablet your first day if you want. Just a little bit. See how your body reacts. and then a quarter tablet the next day, blah, 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 half a tablet. And I always put them on for a few days to make sure they can tolerate the tablet. There's very rare, and they can't do it if they have liver failure, but very rarely a normal liver, someone can go into liver failure with this medication. Yeah. And the injectable form, Vivitrol, you can get, necrosis where you inject, because it's an oil you inject, just like when you inject antipsychotics and stuff like that. So it is, a bit of a commitment, but, then you're a month blocked. You can travel, you're not bound to a pharmacy, you can cross the border, and the border guard doesn't fleece you for everything you've got. Yeah, it's fantastic, 2 minutes. So I usually recommend my patients, I have them drive to the US to get it. That's the easiest thing to do. They just drive across the border to Blaine, Washington. Since it's not an opiate, anybody will give it to you. You can walk into a walk-in clinic. They'll even honor my prescription from Canada in the US, because it's in a totally different drug category in the US. But they push it everywhere. We don't even have it here. No one even hears about it. All these overdose, I see these kids overdose, and I think, oh, if he was on naltrexone, he'd probably be alive. It's just bothersome to me. Bothersome. It's not like it's a panacea and going to cure everything. It doesn't cure the underlying addictive behavior and stuff. You need treatment. You need life. You need land-based therapies and everything else we can throw at it. Analgesia can be different. This is not good for people who are chronic pain patients because it will block all the effect of opiate. If opiates is the only thing you've been effectively using for pain. This is, so there's data on that. So never taking other people's medications and encouraging parents to lock stuff up and calling 911. I tell the kids, instead of dumping your friend in a dumpster because you're afraid of the police, right? That's calling for that. And coke, there's really no treatment, so I'm not going to really talk about that. It's behavioral treatment and contingency management from coke. You get paranoid and use, and your brain, you can really knock your receptors. Methamphetamine, you reverse that transporter, so you actually dump the dopamine out the wrong way. But your brain can heal. This is a methamphetamine user on the left who dished his D2 receptors. You can see in the middle there, a month after being abstinent, still had really low D2 receptors, but after 2 years, his D2 receptor population came back. So, but you need to heal the brain. The brain needs to not have exposure. Yeah, so that's good. I think that's about it. THB, inhalants, bath salts. You can have all my slides. Yeah, that's good. Okay. And there's a case we won't get to just of somebody, crazy high doses of everything, thousands of milligrams of opiates who came in for a back problem into our treatment center. And, within 3 weeks we had him on 6 milligrams of Suboxone. He had no pain and he was great. So it's really quite fun. It's a really great. Okay, and so treating the whole person in the biopsychosocial context is really what we want, despite all my little ranting about different drugs right there. Thank you very much for your attention. I'm sorry we went over a little bit.
refer to that anyway. But Dr. Rieb, take it away.
Great. So I put this talk together for the American Society of Addiction Medicine. I did an hour-long talk there in April on opiate use and withdrawal pain. It's called The Relief That Binds You. So it's in this talk, we'll be able to list 3 pain phenomena associated with opiate use or cessation beyond generalized aches and pains and withdrawal, and discuss mechanisms of that increased pain and identify potential mitigators of that pain and share personal experience with that. So I'd like to hear from you if you've seen this in your patients or tried to treat it. So just to start at the beginning, the poppy plant secretes a substance that we can make into morphine, opium, codeine, or the natural things secreted by the poppy plant. And then there's things that we make that look like those, the semi-synthetics and synthetics. So I'm going to talk about that whole category as opioids. And they have some benefit. They can cause pain relief. They're calming because they suppress noradrenaline. They can give you relief of diarrhea because they slow down the GI tract. And and they also can help you if you're at end-stage COPD, anesthesia during surgery, and end-of-life care. But the adverse health effects that you could see in that video that we were talking about, the worst one, of course, is death, but also overdose that you can get resuscitated from, sleep apnea, testosterone suppression, myocardial infarction, motor vehicle accidents, and addiction. And all of those are a dose-dependent risk. The higher the dose, the higher the risk. By the time you get to about 120 milligram equivalent of morphine, you have a 122 time increased relative risk of getting addicted to the opiate. So it's quite substantial. The thing that most doctors don't talk much about to their patients and often don't know much about, because there's a whole emerging literature, is how opiates themselves can actually not only relieve pain, but actually cause pain. And this area is a really interesting area, and it's the area I do research in. And so I'd like to share with you a bit about that. So I'm going to start at the beginning of how that happened. So this little publication I did in 2011 summarizes a patient that I saw. This is the very first patient I ever saw at the pain clinic. And it's kind of like gambling. If you get a big hit, your first time gambling, a big win, then you're you're more likely to be addicted to gambling. So I had this really, really big hit, the very first patient I saw in my pain clinic. And so I became incredibly fascinated with this area and this issue and this person, and stayed at the clinic still. All these, my daughter's now 14. I started when she was just before she turned 1. So I've been there 13 years. So it was a 39-year-old Caucasian male crane operator. He had his history of a severe crush injury to the left upper limb 4 years ago. He had profound allodynia, which is pain to light touch, and hyperalgesia, which is pain to a painful stimuli, an exaggerated pain to painful stimuli. And this had spread to all 4 of his limbs. And he was diagnosed with this condition we call complex regional pain syndrome, CRPS. It used to be called RSD, reflex sympathetic dystrophy, and a number of other things, causalgia. So he'd had treatments of all types for many years, every kind of medication under the sun. He'd even had a spinal cord stimulator put in. So he'd been through the gamut. He'd had infusions and blocks, and he'd had everything. And so it had spread to all 4 limbs. He said the next thing he was going to is just go into a wheelchair and try to move to a hot climate. That was his strategy for next. So he was on oxycodone extended release 20 milligrams, 6 tablets every 4 hours. Every 8 hours. So 360 milligrams of oxycodone. His morphine equivalent daily dose, MEDD, was 540. So for someone with CRPS, this isn't too outrageous, but what we now know about opiate medication, this is much higher than current guidelines would say, which would be more in the 90 milligram range, maybe a little higher for a condition like this. So this is a high dose opiate user. He rated his pain, even on all this opiate, as 10 out of 10. And just out of not thinking that I was going to do anything with his pain much, but I just wanted to relieve his pill burden. I rotated him to a fentanyl patch. 50 microgram plus a 25 microgram patch every 3 days, plus just a little bit of breakthrough oxycodone. So his morphine equivalent came down to about 330 milligram equivalent. And within 3 weeks, his pain had dropped to 1 to 2 out of 10, and his hyperalgesia and his allodynia had vanished. And he went back to work. And so I thought the guy had a conversion disorder. Like, I thought there's no way that just this and 3 weeks of a pain clinic with, we are multidisciplinary, and he was a little depressed when he came in, but I just thought, no way. But then I started reading more, and I thought, could the opiate have had anything to do with that? And so I started to read, and I'm going to take you through kind of a sequential journey through the literature on how thinking has evolved in this area. So the first physician documentation of this in Western literature that I could find is Dr. Albert in England in 1870 had noticed among his patients that they initially would get some effect with morphine, but then they started getting more and more pain. And so he noticed that, in his words, morphine tends to encourage the very pain it pretends to relieve. And I started to try to find reviews that would help me understand this. And the best one I found at the time was a review done in the year prior to me seeing my patient, in 2002, called Opiate-Induced Abnormal Pain Sensitivity, Implications for Clinical Opiate Therapy. And this is by Dr. Mao out of the Mass General Hospital, Harvard Medical School, who I've done some training with through workshops and things since then. Lovely fellow. He encouraged me to do this study I'm going to show you later. I think this is a really great way to frame things, how his diagram here. So people go on opiate therapy. Then there's some cellular mechanisms that change that can produce, on the left, pharmacological tolerance. And this is the state where the opiate has an effect on receptors and they become kind of resistant. That's kind of classic tolerance. So you just, you keep taking it, it just doesn't have the same effect at the opiate level. And with the case of fentanyl, you can even internalize your receptors and decrease the number of receptors you have and all this stuff. So the body becomes kind of resistant in that way. But there's a whole other thing going on. Yeah, auto advance, I never know how to turn that off. The other bubble on the right side, OIH, for the rest of the talk, opiate-induced hyperalgesia. So it's more sensitivity to pain. It's a little bit of a misnomer because it's not just hyperalgesia, but it's abnormal pain sensitivity. There's a whole bunch of different mechanisms I'm going to go over in the body that creates a state where the opiate itself can actually cause more pain sensitivity. And those two things combined, the kind of resistance at the receptor, and then which is true tolerance, and then the pain sensitivity, they combine so that it looks like the patient is tolerant to the drug. That's apparent tolerance, the block at the bottom. And the patient's in a worsening pain state. So what that means is that when we put patients on opiates, they get some initial pain relief, but then soon the body adapts and gets resistant to the opiate itself and starts to make all these adaptive changes in the nervous system that make you more pain sensitive. And then it looks like you have more pain, so what do? We put up the opiate because initially they'll get some more relief because we've kind of loaded them again. And then this thing happens. And what I was taught in medical school was they get tolerant, who cares, just put the dose up, And so we did. We put the dose up, and then we'd put the dose up, and we put the dose, and that's how we get people on thousands of milligrams of morphine. In truth, people get pain relief. Usually 80% of people will have as full of pain relief as they'll ever get at 80 milligrams. And at most, 1 in 3 or 1 in 4 people are opiate responsive is what we found over the years, up to about a few years ago. And the new Canadian opiate guidelines, I listened to Dr. Bussey in his analysis of all the world data. He said that actually what we found now is if you look at all the world data, it's only 1 in 12 people are truly opiate responsive. That means 11 out of 12 people we should be taking off opiates. But what happens is you also get noradrenaline suppression. So if you've had any trauma, that feels really good to be on an opiate. So it's not just the pain relief, but it's the sedation and the relaxation. And then within even a month, you start to make these changes, even less, where you get tolerant. And if you take a tolerant patient off an opiate, what happens? They get withdrawal, exactly. And then they have to take it. And so then they start confusing their withdrawal state for a pain state. They think they have to take it for pain, but it's the pain of withdrawal. So they get on this endless kind of circle. Another study that I thought was pretty key at this time that came out, the year prior to Dr. Mao, and he'd integrated that into some of his findings, is that people who are going in and out of withdrawal a lot build hyperalgesia faster. So for example, if you're a heroin addict and you're, going in and out of withdrawal trying to find your drug, you don't have a steady supply, they got more hyperalgesic. So the magnitude and the duration of the heroin-induced hyperalgesia increased with intermittent administration. And there are blockers of the NMDA receptor that prevented both heroin-induced pain sensitivity and naloxone-precipitated hyperalgesia. And that's your glutamate pathway. Glutamate binds to an NMDA receptor. And we were talking about glutamate through the earlier talks today, how important it is. It's your excitatory neurotransmitter. But it's also the pathway by which, one of the pathways by which you get both tolerance and hyperalgesia developed. And if you block that pathway, that can provide some help. And this lovely study by Peggy Compton, she looked at pain intolerance in opioid-maintained former addicts on long-acting agents. And so she wanted to see, okay, maybe that's just people while they're in withdrawal and stuff, but if we put them on methadone or Suboxone and buprenorphine, won't they be better? And what she found is no, actually, they're quite hyperalgesic. And the kind of test she did was called a cold pressor test. I just want to ask a question. I'm getting a little echo feedback. Is that just me hearing it, or am I doing something wrong? Am I too close or too far? Should I talk in rounder tones? Okay. Okay, is that better? A little less echoey? Still a little echoey, but that's okay. I was with Peggy, wasn't I? Yeah. So she did cold pressor test, and that you take this vat of ice water with ice cubes floating, and you shove your arm in, and you wait. And when you first feel cold pain, it's like a C-fiber pain, that's your pain threshold. And then when you can't stand it anymore and you have to pull your arm out, and then you're, that's your pain threshold, your tolerance, pain tolerance. So pain threshold, pain tolerance. And she found that these were changed in both methadone and buprenorphine patients. Not as encouraging as we'd hoped. And there was this initial tiny study looking at chronic low back pain patients before and 1 month after initiating oral morphine, just to see how long does it take to get hyperalgesic? How long do these changes take? And on a cold pressor test, they did pre and post morphine initiation a month later, and also at the end of the month, they gave everybody remifentanil, which is a strong opiate that you'd give intraoperatively, to see if they're tolerant or not. How do they respond to remifentanil? And all patients became hyperalgesic as well as tolerant within 1 month after oral morphine. So we know that you can get tolerant and hyperalgesic within a month of outpatient oral therapy of morphine. So then Justin Hay and Bruce Rosenfeld's group did some looking at hyperalgesia in opiate-managed chronic pain and opiate-dependent patients. Is there a difference between patients who have pain, patients who have addiction? Maybe we're talking different populations. So he took 40 patients and divided them into a control group, those who are on methadone maintenance for pain, those who are on methadone maintenance for addiction, and those who are on morphine. And chronic non-cancer pain and opiate use disorders both were hyperalgesic with cold pressor tests, and there was no hyperalgesia with electrical stimulation, which is interesting because I did my master's on acupuncture-like TENS, so transcutaneous electrical nerve stimulation. I did it on TENS and found I couldn't change electrical pain thresholds using TENS. Electrical pain threshold is a really hard measure to change, so it doesn't correspond very well to chronic pain situations. It's better to use cold pressor test, really, or heat pain test, and I'll show you some studies with heat pain. So some of the best work in the field was done by Michael Hooten. He's out of the Mayo Clinic in Rochester. I've lectured with him at some pain conferences. He's a great guy. And he took 187 consecutive patients entering his pain program, 85 on opiates, 102 not on opiates. And if you look at the study, they don't really vary significantly in the types of pain disorders or how strong they rate their pain and how functional they are. They're basically pretty similar patients, except one group's on opiates and one's not for their pain. And the patients taking opiates had lower heat pain tolerance. They were more hyperalgesic. When you shine a heat lamp on them, they pull their arm away much faster. So you could see it's starting to, and these are people living in the community coming in, not in a, acute hospital pain situation. And so some of the mechanisms that have been proposed from this is that it's separate from tolerance alone, although they have some similar pathways, that glutamate can be involved because the NMDA system is altered, the receptors are altered. It changes central pathways, your dorsal horn, rostroventral medulla, the raphe nucleus and the somatosensory cortex all get changed. Your dynorphin cell destruction can occur at high dose, so you can actually kill off cells. There's alteration in GABA, cyclic AMP protein kinase, microglial activation via toll-like receptor 4, which I'm going to talk more extensively on because that's a more important aspect of this, and release of neuroexcitatory substances like substance P, nitric oxide, prostaglandins, growth factors, and pro-inflammatory cytokines, interleukins 1, 6, and tumor necrosis factor alpha. Isn't it ironic? I mean, you're trying to treat somebody with an opiate. It's so natural. You can get it from a poppy plant. There's all these arguments for opioid use, and patients love you to put them on opioids because there's so much initial pain relief and it's so relaxing. But what we end up doing is creating all of these changes in the nervous system that can add to pain. Here's a nice schematic that Dr. Jane Ballantyne, she used to run the Harvard Pain Clinic for 20 years and now works in Seattle. She emailed this diagram to me from her paper, and it's a good paper. I have a reference to it in the back. But it really well summarizes how the peripheral nerve coming in, the dorsal root ganglion, all of these factors that I've listed, some of them on the previous slide, can get affected on the way in by an opiate. And then the ascending, the dorsal horn gets affected itself in all sorts of different ways. And then the ascending pathways, the brain changes. And then the descending pathways, and again, in the dorsal horn. So the glutamate pathways, dynorphin pathways, and everything. And we'll talk more about the glial in a minute. But there's multiple layers now, and there's people doing research on each of these layers. There's teams and teams of people doing research on each of these layers, trying to find a drug to block it, or trying to find something to do, or some way to keep taking opiates but block this effect, or give a different medication that would block this effect. So I think the biggest news in this field has been the understanding now of the role of the glial cell. So when I was going to medical school, glial cells were just support cells around neurons. They were like insulators. That's what I was taught, And then we learned that, well, maybe they nourish the cell as well. But it's a nourishing insulator cell. That's about all glials do. But there's a lot of glials, There's more glials than there are neurons. Astrocytes, microglials. There's a lot of glials. So it turns out that glials do a lot of things. And in the natural world, if you get a nerve injury, you get an irritation of your sciatic nerve, and they can reproduce this by doing this nasty little experiment where you take a rat's sciatic nerve and you tie a ligature around it, because we're surgeons, and you give it an anoxic injury and you untie it, right? So that it's had compression, kind of like a disc herniation or something, right? It was compressed for a bit and then you undo it. And so the nerve's still working, but it gives a lot of neuropathic pain. That nerve is distressed, and it will secrete chemicals, and the glial cell will pick up some on those chemicals, and the glial itself will start to release inflammatory cytokines and make the nerve more irritated. Why would that be adaptive? Why would you want to irritate a nerve that's already irritated? What do I want you to do if you've hurt your nerve? I can't hear. I'm not hearing. Stop the behavior, exactly. So, like if a dog bit your leg, you want to kick the dog, run away, and lay down so you can heal. You want to heal. So we're wired for acute pain, not to understand chronic pain. We're wired to understand acute pain. So your body would, secrete some inflammatory cytokines and then call your immune system to come. Because if I have so much pain, something must have torn into my leg. So you get the whole immune system involved to mop everything up. And then the glials start to, after about a certain length of time, the glials will then secrete anti-inflammatory cytokines, calm the whole thing down, send everybody home who's come in, fire department, ambulance, everybody goes off, and then the nerve settles down. But if you take an opiate, that doesn't settle down. The opiate will cause the glial to keep secreting inflammatory cytokines and keep neuropathic pain going. If you give a blocker to an opiate blocker, it will block the toll-like receptor 4, and you won't get inflammatory cytokines released from the glials. So I'll show you this in this diagram. Let me make sure I didn't go too far ahead. So anyway, it's a great article to read by Mark Hutchison, who's out of Australia, and Linda Watkins out of Boulder, Colorado. She's a great speaker. She has a great lab and has done amazing work on glial cells. But opiate-induced glial activation, mechanisms of activation, and because it has implications in the whole nervous system. So they've shown how it not only does it affect how opiate analgesia works, but also drug dependence and the reward system is tied into glial cell activation. So it's a good article to read. So I'll just talk about the neuropathic pain component. So if this is your neuron and this is the next neuron, the glials surround, and normally you just be secreting, your nice little glutamate neurotransmitter information for excitation. But if you take an opiate, these little white things floating around, they'll bind to these toll-like receptors on the glials, these little purple ones, and the glials secrete all these red dots, this inflammatory cytokine, and piss off the nerve and keep your nerve irritated. And that cycle, and the more irritated it is, the more opiate you take, and then on you go. So you think of how many people we are actually, this is part of the mechanism. And we find when you detox people from opiates, the vast majority of people have less pain than they had at the beginning, or about the same, but they're clearer. But a lot of people's pain scoring comes down when you get them off chronic opiate therapy. Not if you do it fast or too acutely. Anyway, if you give a blocker that blocks the toll-like receptor 4, and naloxone and naltrexone are both blockers of toll-like receptor 4, you'll block this effect and you won't get a hyperalgesic response. Anyway, did you have a question? Anybody? No? So glials can both be protective and be pathologic in chronic pain. And some of the mitigators of opiate-induced hyperalgesia that we found is opiate rotation. If you rotate to a new opiate, you're not so tolerant with that opiate, and the glials may not have exactly the same response. And also, opiate lowering can help this response. And what did I do with that first patient I showed you? Unknowingly to me, I had opiate rotated him and opiate lowered him. And he had no hyperalgesia. Interestingly, after about 4 months, his hyperalgesia returned because he was on fentanyl for after about 4 months on fentanyl, and then he had to go off work. So it wasn't the cure. The cure, once he had that response, what did he need? He should have come off completely once he got hyperalgesic again. Or you'd have to set him up to rotate every few months to different opioids, like you would a palliative patient that you're trying to get good control over. NMDA receptor antagonists have been shown to work, ketamine and other things I've listed, dextromethorphan. In animals, you can't get a high enough dose of dextromethorphan usually in a human to have enough of an effect. Non-steroidal anti-inflammatories have been shown to help, strangely enough. High-dose ketorolac, ibuprofen, or COX-2 inhibitors. Gabapentinoids can block opiate-induced hyperalgesia. Gabapentin and pregabalin. So, we talked about gabapentin, and pregabalin can also be used, Lyrica, but can be used in opiate tapering protocols that have been found to help. Well, one of the reasons is because you're blocking some of the opiate-induced hyperalgesia. Then alpha-adrenergic blockers, because it turns out, who knew, but that adrenaline and noradrenaline actually can activate your neuroinflammatory system so that you have a lot more hyperalgesia. I'll give you an example of a study that was done in rats, rheumatoid arthritic rats. They took RA rats. Sorry, it's a rat experiment again. Oh. But you take the little rats and you chuck them into cold water and make them swim to shore. And when they get to shore, their joints swell because it's a stress experiment. And these are genetically RA rats. But then you sympathectomize them, so you cut off their sympathetic nerves and chuck them back in the water and have them swim to shore. So not their motor nerves, so they can still swim, but they get to shore, and the one side that was sympathectomized is not swollen, and the side that did not have the sympathectomy is swollen. So we know that that your autonomic nervous system and the secretion of adrenaline and noradrenaline causes swelling, neuroinflammation. So there's a lot about that that's come out. So your nervous system, your immune system, and this auto-inflammatory systems that are present in the body play a big role. And alpha blockers that block this adrenergic system can really be helpful in this process. And what did we show you? I showed you earlier, for years and years and years, we've been using a Clonidine protocol, an alpha blocker, to help with opiate withdrawal. Isn't that strange? But now we know it helps to block opiate-induced hyperalgesia. And then beta blockers, propranolol and other beta blockers. Cannabinoids, there's only a tiny bit of evidence, and it's not in humans yet, that it may be helpful. And melatonin has been shown in human and animal models to help. So when we're thinking about things for sleep, lidocaine as well. And we do lidocaine infusions for CRPS and other very painful conditions, ondansetron. And then microglial toll-like receptor 4 antagonists, enantiomers of naloxone and naltrexone. And there's a medication used in Japan called Abutolast. Have you ever? Yeah, it's not available in Canada, but it's an anti-inflammatory, but also affects the immune system it's a toll-like receptor 4 blocker, and it doesn't have, you can still take an opiate when you're on it, but it's been highly effective for RA, and it's used in MS and other things like that. So we may, it's been used for over 30 years. And minocycline also, interestingly enough, is a toll-like receptor 4 blocker, and it's used in certain conditions. Neurosteroids also have been shown to be an effect. Progesterone, etc., can change how your toll-like receptor 4s operate. Now, all this research is fairly new over the last 15 years or so, so there isn't a drug that's been approved for opiate-induced hyperalgesia through Health Canada or the FDA. So these are all studies, preclinical and clinical studies, but just to give you a background on what the kind of research is going on. Just to know that there are lots of studies, and this is one of the earlier ones, showing that there's significant pain reduction in most chronic pain patients after detoxification from high-dose opiates. Retrospective study of opiate detoxification, 23 patients, 21 of them had significant decrease in pain. And then gabapentin improving cold pressor response in methadone maintained patients. Cold pressor pre and post initiation of gabapentin. Gabapentin reduced the cold pressor sensitivity. And this naloxone and naltrexone have two enantiomers, and one of the enantiomers blocks the mu-opiate receptor, can block the opiate, and the other one blocks the toll-like receptor 4. So we may be developing medications that you can just pull out the one that blocks the toll-like receptor 4 so that it'll block neuropathic pain. And there are some pain conditions now with people who aren't on opiate medicines that we just give naltrexone for. So even MS and other conditions that we're giving low-dose naltrexone for. So how about withdrawal pain? So some of the first recorded in the English literature, the English lay literature about this was Thomas de Quincey wrote this very interesting little biography of his own experience called Confessions of an Opium Eater. Has anyone read that? Yeah, so it's an interesting thing. And in amongst his writing, he talks about using and withdrawing from opium causing a state of internal rheumatism. So he's achy inside. And we always just think about, yeah, that's just withdrawal. But why is that just withdrawal? What is that? Why do you get achy? So the opiate-induced hyperalgesia is one part of it, but also the withdrawal state itself will cause lowering of dopamine, which can cause a feeling of being depressed, grief, loss, lethargy, amotivation. And then as you withdraw, because opiates suppress your adrenaline and noradrenaline, you come off your noradrenaline rebounds. So you get lots of anxiety, insomnia, worry, perseveration, agitation, aggression, activation of traumatic memories, and flight, where you want to run away. So there's a state we now call not just opiate-induced hyperalgesia, but withdrawal-induced hyperalgesia. It's also known as opiate withdrawal hyperalgesia. It's an unmasking of that opiate-induced hyperalgesia as with opiate cessation, which can cause pain because you no longer have the opiate to help with pain. You only have the pain induced by the changes. And then also all this massive release of noradrenaline when you're in withdrawal adds to pain. So those two things together give you a withdrawal state that produces pain. Even short-term infusion with remifentanil, it's an opioid, during surgery can cause hyperalgesia in withdrawal and make people more pain sensitive after they've had a surgery, even for a few hours. And then Dr. Younger had done a very good cold Pressor test looking at chronic pain patients after they've detoxified from opiates. And he found that more patients had not just hyperalgesia when they were on the opiate, but when they came off, they had even more hyperalgesia due to these withdrawal things. And Dr. Younger then again did another follow-up study looking at the association between heat pain perception and opiate dose in patients with chronic pain undergoing tapering. And he found that it was dose-related. So the higher your opiate starting dose, the more hyperalgesia you had. And tapering from higher doses was associated with lower values of heat pain, so you're more hyperalgesic. So in over 109 patients, it was a dose-dependent effect. So the higher the doses we put people on, be that for pain in this case, or even for addictive disorders, you know, the huge doses of methadone we use, you know, we can make people very, very pain sensitive. And many, many, many patients who are on either heroin or who gets, or oxys off the street and then get switched over to methadone and everything, they still complain of massive pain. They're getting huge opiate loads. Why would they have pain perception? Often there's over 50% of methadone patients usually endorse having chronic pain. And they're in pain all the time. But what we're doing is often adding to their pain situation. Abnormal heat and pain perception in remitted heroin dependents months after detoxification. So they took, this group took 23 patients and looked at them months after stopping methadone, and they remained hyperalgesic to heat for up to 5 months. It took them 5 months to reset their nervous system after you stop methadone. So we need to consider that. There's also some studies that show in patients who have chronic back pain, when they've been taking off high dose and no addiction, but just chronic low back pain on high dose opiates, it can take 5 or 6 months for them to reset their hyperalgesia as well, for their pain thresholds to become normalized. And what happens instead is patients try going off for a day or two, they have withdrawal pain, and then they get they're hyperalgesic, and they think they need their opiates, they have to go back on. We never tell them when we start, well, you know, once we put you on this, to get a normal pain threshold again, it'll take 4 or 5 months. Like, that's a different level of informed consent now. So what are possible mitigators? There's a lot of work going on in this little micro world, my little micro world. And then, again, NMDA antagonists, nonsteroidal anti-inflammatories, gabapentinoids, alpha and beta blockers, cannabinoids, melatonin, microglial antagonists, opiate tapering, rotation and then tapering, instead of abrupt stop. So instead of stopping quickly, put them on something, rotate, get them down. So that's what we're doing in most detoxes now, hey? We're putting them on Suboxone or on methadone and tapering them down slowly, and people have much less pain. Well, on top of just withdrawal pain and on top of opioid-induced hyperalgesia, there was something else I was noticing in the patients in the detox settings I worked in. I noticed that patients, not only did they get general aches and pains, but they also hurt more at their previous injury sites. Anybody ever notice that your patients during opiate withdrawal complain? I see a few heads nodding, hurt at their injury site? No? Yes. Okay. Yeah. And I noticed that occasionally I'd see a patient who'd had a previous injury that was healed and pain-free before they got wired to an opiate. Let's say they were in a motorcycle accident when they were 17, or I should say 19, once they legally can drive, and then broke a femur. It got all healed up, but then when they were 25, they got wired to heroin. But every time they withdraw, their femur still hurt, but it would go away once withdrawal was over. So it was like this incredible memory of pain that would come back during withdrawal. And I thought that was interesting. And then all these pain patients that I saw in my pain clinic on high-dose opiates who never were off since the time of injury, once I tapered them off, there was about 10% who didn't have any pain. So I wondered if they were the same population, so I did a little study. Dr. Mao encouraged me to do this. He hadn't seen it much because he didn't work in addiction where we tear people off in the days when I started. Just detox people quickly. And so I did this study called looking at this phenomenon of pain recurring to an old healed injury site. I called it Withdrawal Associated Injury Site Pain, or WISP. It's the acronym. My husband did the drawing. mny.ca. Yay, Michael. I'm very fortunate, after working with the editors for about a year, we finally got it published in the journal Pain in December. And I acknowledge all my co-authors here, it was a long, arduous process from starting to finish. It took 4 years to get the study done, but I'll walk you through it. If you want to read this study, I'd really encourage you to take that link and download and squirrel your way till you get to the journal Pain and download it. I paid almost $4,000 Canadian to have that be open access for people to be able to read. And the more you click on it, the more the journal knows that pain and addiction are actually important issues and are more likely to publish people who want to talk about that in pain journals. So the objective was to document and characterize the clinical observation that pain can return temporarily to old, healed, and previously pain-free injury sites during opiate withdrawal. So I designed a mixed method exploratory case series, developed a new survey with 5 screening questions, and then the patient could go on if they wanted to, if they screened positive, to 35 descriptive questions. They could either do an online survey or self-administer it. And if an online survey that was self-administered, or if they lived in Vancouver, they could choose to be interviewed. And I did all of the interviews myself, one-to-one. They were 45 minutes to an hour each. And the participants recruited were via poster and bookmark, and the pain and addiction treatment programs around the city and an inner-city research office through November 2013 to June 2015. They had to be over 18, read and write English at a grade 8 level or so, and not be impaired while I was interviewing them. And UBC and Vancouver Coastal Health Research Boards approved this. We did a quantitative analysis on the data. So this was our recruitment poster. So you can see I didn't care if they were taking pills or shooting, if they had an addiction or a pain problem, but they had to have had a previous injury that was healed and pain-free before they went on to opiates. These were the questions, the 5. Have you ever used opiates daily for 3 months or more? They needed to have some degree of dependence, physical dependence, tolerance. Have you ever had a significant painful injury that was healed and pain-free for at least 3 months before starting an opiate? And during that pain-free time, were you off all other pain medications? And have you ever been 2 weeks or more off opiates since starting daily use? Have you ever had a temporary return of pain at your old healed injury site when you stopped? 58 people completed screening, 31 by interview. Most were recruited from inner city office. So you can see I purposefully recruited for people who'd had this condition. So I tried with the screening questions just to make sure they had it. 47 screened positive to have the phenomena of withdrawal-associated injury site pain. And of those, 34 went on to complete a full survey. 21 were by interview, so I personally did those interviews. The demographic, the mean age was about 45 years old, 62% were male, 71% white, 27% First Nations. We had one black patient, 3%. 68% had a grade 12 education, so it was an educated population, and 67% were unemployed. And the original injuries that they endorsed having, most of them were fractures, some soft tissue injuries. It was very, very bad sprains where they'd tear things apart and had to have surgical repair, or very bad post-op infections after surgical nightmare stuff going on. And then I also explored themes with the patient. I asked them things about and let them explore, and would alter my questions for the next person based on what they said about their bodily experience of WISP, the emotional aspect of this, having this condition, how it affected their opiate use behavior, and also how it mitigated, what things they took that lessened it, mitigators of WISP. And then I asked them about their own theories. Why did they think pain came back to their injury sites? Like what do they think was going on? So really tried to do exploratory research here. So what the findings were is that the intensity of this phenomenon was quite high. The median rate was 8 out of 10. In the pain world, we rate anything from 8 to 10 out of 10 as severe pain. And how they rated them, at least this is the memory of it, because they're not in it at the moment, but their remembering of their original injury was 10 out of 10 pain. So these were very, very painful original injuries that they could recall. But about 35% of them rated WISP as even more painful than the original injury, so they might have rated it a 9 and WISP a 10 kind of thing. And the intensity of WISP compared to their withdrawal pain, 35% said it was, the intensity of WISP versus withdrawal pain, it was more painful for the vast majority of patients. 65% said this was like much worse than regular withdrawal, but not as bad as the original injury. And how long did it last? About 14 days on average from stopping their opiate to letting the symptoms go. But there was quite a wide range. You can see anywhere from 1 to 70 days. And we had 2 outliers, one at 120 days and one at 365 days. That was a methadone patient who said he hurt and hurt and hurt and hurt and hurt, and it finally went away slowly. And by 1 month, 82% were over. So that leaves 18% of people who last longer than a month. So when people say, you know, how long will it take for me to get over withdrawal? Well, some of your withdrawal symptoms might go away, but the pain at your injury site, it may take over a month for us to know what your baseline pain's going to be at your injury site when you come off an opiate. During withdrawal, they rated their withdrawal time as being about 13 days. So it seems to be a withdrawal-related phenomenon. And I just wanted to point out, in those who could recall their opiate dose, they were on these patients were on super high dose opiates. The mean morphine equivalent dose is between 840 and 962 milligrams. So these are high dose patients, and most of them stopped abruptly. And you can see morphine, heroin, oxycodone, and methadone were the most used substances. And they had in brackets are the percent, and you can see how many people had very extreme withdrawal symptoms. A lot of adrenergic withdrawal symptoms, runny nose and hot and cold flashes, sweating, and a lot of severe withdrawal. So let's talk about what they thought was going on, which is quite interesting. I don't know where auto advance, I can't stop it. Okay. So WISP versus your original injury, how did it feel? God, it felt just like it did when it was healing, when it was broken. Yeah, I don't know how, any other way to describe it. This was a 53-year-old white male. His original injury was a fractured arm at age 12. And WISP versus the withdrawal pain, I was pounding my legs. Old injury sites are horrendous, so it's like more severe in those spots. The other part of you can like get through with a hot cloth or whatever, with gravel and stuff. But the old injury sites come back with like severe severity. So this was a 58-year-old Indigenous female. Original injury was foot fractures requiring plating and lower leg injuries requiring fasciotomies after a home invasion, capture, and repeated assault with a hammer. And how some of the quality was neuropathic. It's just almost like shooting up the back of my leg combined with pressure in that area, as well as, I could feel my skin stretching and the sensitivity to touch was increased. So it had both kind of an inflammatory and a neuropathic kind of quality to it. This is a 35-year-old white male. His original injury was an ankle tear requiring casting. And then more on that inflammatory note. Yeah, it was restricted motion. I think the texture, the back of my wrist, it became woody. I deliberately went through wrist stretching exercises to get my wrist flexibility back. This was a 62-year-old white male physician. Original injury was soft tissue inflammation and infection in the dorsum of his left hand after fentanyl injection. He was addicted to fentanyl. The first guy I interviewed. He's a friend of mine. That happened to. So I asked, how did it affect their drug use? And 79% said having WISP, having a withdrawal-associated injury site pain, made it harder to stop opiate use. 85% said they wanted to use an opiate again to make it stop. And then 44% said in one of their relapses, they did take an opiate just because of that condition to make it stop. So it looks like it's in the preliminary work here, that it may be a risk factor for repeated opiate use. And this has been something missed in medicine. We don't usually talk to people, when they talk to them about their opiate use habit, we don't usually talk to them about, is the barrier withdrawal pain for you? Is the barrier pain at your old injury sites during withdrawal? And if so, we need to help you treat that with all sorts of different things. So then I asked the patients their theories of what they thought was going on. So they said things that I expected, which was it's all part of the drug withdrawal, or I don't think it healed right, so thinking it was a chronic pain condition. And then some thought, oh, it might be psychological. I must be making it up because it goes away. It's a phantom. It's a mystery. And then they came up with some really interesting things. So one patient thought it had something to do with their own endogenous opiate system. I think WISP occurs because of lack of my own body producing a painkiller. That it's just sensitive due to the injury. And when I'm in withdrawal, my body's way too sensitive and there's pain there that's not being handled right. Then my body kicks in its own morphine to cover it up because it helps with, the tolerance and the damage that's done there. So that's pretty insightful. Talking about endorphin and enkephalin suppression in their own words that you get with opiate use, so you don't have your own endogenous painkiller on board. Yeah, that's going on. That's interesting. And then kind of another theory that was more along the addiction line. This was a guy in recovery. He said, I thought, okay, it's such a strong pull to do the drugs that my brain figured out that because I started taking opiates when I sprained my ankle, it's going to start kicking the pain out at the ankle to get more opiates. Because my brain was subconsciously craving it. And the primal part of my brain, it just wants to communicate. It communicates at a basic level, right? So it's going to be pain, pleasure, right? I honestly do believe it's a form of communication between the primal part of your brain and your prefrontal cortex. He was an engineer in recovery. Pretty cool, hey? And his ankle would swell whenever he'd withdraw, and it would go down. So he had this neuroinflammatory response. And so patients often think, well, it's swelling, it's real, whatever that means. Yeah, it's real, it's swelling, but why is it swelling? It's swelling because you have noradrenaline cascade and you're in opiate withdrawal, and that's why it's swelling, not because it's damaged from an original issue. Anyway. And then I had one patient who was quite articulate. A few patients thought the opiate might be playing a role, but one patient was more articulate. She said, in hindsight, I never correlated oxy use to actually producing pain, but in my experience, that's pretty much what happened. Addiction promoted pain. So she's a 34-year-old white female. Her original injury was a minor knee twist playing basketball in junior high. And then when she was in university, she started with her friends snorting oxycodone and got wired. And then when she withdrew, she had knee pain. And it was just, lasted a few weeks of withdrawal and knee pain. And then she was fine, running around. And then she started snorting oxy again, and she got knee pain when she withdrew. And then she started snorting oxy more. And then she started noticing as the dose of oxy was going up and up and up, she started getting knee pain at higher and higher doses of oxy too. So I wrote her case up because she's kind of that canary in the mine shaft or whatever. She's telling us that, how that can progress, that the opiate use itself can cause the sensitivity, and then withdrawal unmasks it, and you get all this added pain at the site. But so many of our patients, I think, definitely is a higher incidence of chronic pain in the addicted population. There's no question about that. But there's a lot of people who I think are mislabeled by medicine and by the patient themselves, thinking that they have chronic pain disorders when actually it's being driven by opiates. So I asked patients if they could recall anything they took that made this better other than an opiate, which obviously would make it stop by going back on an opiate. And about 19 of the patients, so 56%, could think of something. I didn't prompt them. I didn't give them a list and say, of these opiate-induced hyperalgesia mitigators, which one worked for you? I didn't say that. I just let them free-form and tell me. And so 89% named one or more anti-inflammatory, non-steroidal anti-inflammatory. Ibuprofen was the most common. Some said ketorolac, some said meloxicam, depending on what they'd been exposed to, naproxen, but mainly it was ibuprofen and Toradol, ketorolac. And then you can see a fair number said acetaminophen, 32%. I'm not highlighting it because there's no other literature on that, but maybe there's something to do there. And then interestingly, 16% said gabapentin or pregabalin. And then one each named ketamine, phenobarbital, cyclobenzaprine, alcohol, cannabis, topical menthol, and camphor. And there is evidence for each one of those things, aside from the menthol and camphor for opiate-induced hyperalgesia. There's evidence for menthol and camphor for pain in general. But each one of those other things has been shown to affect opiate-induced hyperalgesia. So I thought it was super interesting. It's just not a very big population I'm testing, but we're having our little foot in the door here. And then several said opiate rotation to buprenorphine before tapering was the best thing that ever happened to me. I avoided getting WISP. And one said rotation to methadone before detoxification helped. And one said methadone maintenance suppressed the WISP, but they'd just gone on it, so she's the same patient who had the knee injury, who I just followed up with 2 years later, and she told me she's off methadone now and on Suboxone because it didn't work long-term for her, the methadone. All the patients who had been on methadone said methadone gave them the worst withdrawal-associated injury site pain of anything when they tried to come off. So it was the hardest drug to come off of. Their joints and any injury site hurt like stink. So that's something to keep in mind. Another reason to use buprenorphine, Suboxone, for opiate maintenance therapy, okay? Or if someone wants a sober route, if they're ready for that, to consider naltrexone. It's a toll-like receptor 4 blocker. You're going to reduce hyperalgesia, and you're not going to give them opiate-induced hyperalgesia. So trying to use naltrexone if you can, if they have a condition that you can, addiction and a pain condition. Great. Several said calming techniques lowered their WISP. So isn't that interesting? What are they doing? They're suppressing their noradrenaline release, so they're altering that. And in my pain clinic, I've worked there for 13 years. I've seen thousands of patients, and in my career, tens of thousands of patients. And what's interesting is, both in addiction treatment and in pain treatment, we teach self-regulation techniques, mindfulness meditation and breathing techniques and things like that to help people calm down. But when I do all the exit interviews at our pain clinic, and I would say about 80% of people, when I ask them, if you could pick one thing that helped you the most in this 6-week, 5-day-a-week, 8-hour-a-day program that we've given you, what's the one thing that you've been taught that's helped you the most? What do you think they say? They have physiotherapy, occupational therapy, psychology sessions. They get meds from me. Mindfulness meditation. That's the thing that's helped them the most for about 80% of the patients. And it's because you calm. You learn, or breathing techniques. They'll say one or the other. So you learning to calm yourself and calm this response can really help. Anyway, okay. Then, so we know that withdrawal-induced injury site pain can be severe, that the original injury tends to be a very severe injury, that WISP is less painful usually than the original injury, but more painful than the general withdrawal. It lasts 2 weeks or sometimes more, sometimes months. It's aversive, emotionally aversive. I skipped that somewhere. And relapse, it adds to relapse, and that patients have theories about it. There's one slide that we must have auto-advanced. I just want to show you this, how the aversion, the emotional aspect, this is it. This one, patient number 8, he said, there's also not just the physical pain. I was run over by a semi, so I suffered some physical injuries that came up in withdrawal, but also there's the anxiety from it too. It's like PTSD from that time. He's a 38-year-old white male construction worker with a previous multiple bilateral lower leg and foot fractures after being struck and pulled underneath a semi-trailer. So this guy was interesting because he had an experience. He used to use heroin and knew what withdrawal was, in and out all through his late teens, early 20s, and then he got sober. And he was doing great, working as a construction worker, leading a sober life, and he walked across the street, jaywalked, got smacked by a semi, sucked under, crushed both legs, 16 fractures each leg. He got treated, did have a bit of opiate during the initial fracture stuff, but healed up quickly, wanted off opiates, was opiate-free, after about 9 months, completely pain-free, completely opiate-free, and went back to work. Was doing great, but then heroin called his name. Due to addiction, he was very clear, not due to pain, because he was pain-free. But then he started, ramping up, and then every time he withdrew, he had pain in his legs like he'd never had before in his normal withdrawal prior to this. So he was his own control, really. He was like his mini own control group. Because a lot of people say, well, everybody gets pain in withdrawal, like who cares? But this guy was like, no, this is different. He said, this is like having hot molten lava poured over my lower legs, like when I was shoved under, got sucked under the semi. He said, this is a very different experience. And it's so painful. He said it was like having all the skin stripped off you, and it's just bone and nerve left that you'd have to walk on his feet. And so what he said he would do is for 3 weeks after he would stop his opiate, he would have to crawl on his hands and knees to the bathroom and back, and he'd just stay at home crawling. And that was it. But after 3 weeks, he had absolutely no pain. He could walk, he'd do everything was fine. And then he'd relapse. And he has a very bad addiction. So he has relapsed over 200 times, tried to get down and off of this. He's made it through 3 times over 2 years, been able to come off completely, and every time absolutely pain-free, nothing. So anyway, that's why this aversion, this emotional component, adding more to the adrenaline release and the trauma and the memory. And a lot of pain, as we know, has to do also with your hippocampus. Your memory of the pain gets overlaid with the actual pain itself, and the trauma of the event and the meaning of the event and the catastrophizing of the event and the fear of the future if we keep going down this route, how it's going to feel. All of that tumbles into this pain experience. So it's kind of like a little mini microcosm of what pain is and chronic pain is, all kind of in one. We think that there is a form, we know that the nervous system, if you get a very painful injury, it can alter your spinal cord and your brain. And that's called central sensitization, where you then have something not painful can produce pain, or a mini pain can spread. So your nervous system can get more sensitized and have a lower pain threshold. And usually that will self-correct and your body will be normal again after. It's a temporary thing. But in chronic pain conditions, it can go longer. But it looks like that somehow during the withdrawal phase, that central sensitization or perhaps peripheral sensitization gets unmasked somehow. And so this comes up. This is some of my theory about how this could actually be produced. Also, high-dose opiates may be playing a role, like with opiate-induced hyperalgesia, and multiple withdrawal episodes. Most of the patients I interviewed had been intravenous drug users at one point or high-dose oral users. And abrupt cessation seems to be playing a role in that noradrenaline release, the neuroinflammation, and the neuroimmune component. The problem with this study is that the survey was self-administered by some, and I did all the interviews, so I could have been biased. The patients could have had a recall bias, and it wasn't designed to calculate prevalence. So I had these little pocket of patients I found over 2 years that had it, but really, does it mean anything clinically? Is it really important? And I didn't control for things like tobacco smoking and mood, and those things impact pain, and I didn't do that. So I went on to do a much larger study that I'm just finishing writing up now. So this is pre-release. This is your preview. You put on your 3D glasses now. So I looked at withdrawal-associated injury site pain among people who inject opiates in Vancouver. So we looked at the long-standing cohorts that have been running in Vancouver in the HIV course, the VITAS study, the ARISE study, like this, that have been going on in the Downtown East Side for over 20 years, and we added questions to that. So we looked at the frequency and impact of WISP among people who inject drugs, since it hadn't been previously examined, and we used data, as I said, from these ongoing studies to look at the prevalence and correlates in a multivariate analysis. And so we simplified the questions because we had a community group who looked at my 5 screening questions and thought they were too complicated for the population. And we get community input, even though it wasn't what I wanted, but you have to, but what if no one will accept our paper now because we've changed the criteria? But anyway, so this is what we came up with, and it's very good. It's very, very similar, but perhaps clearer for the population. So have you ever had a serious physical injury, like a broken limb or other physical trauma that's healed and usually pain-free? If yes, during withdrawal from heroin or other opiates, have you ever experienced the temporary return of pain focused at one of your old injury sites? If yes, does this pain at your old healed injury site impact your use of heroin or other drugs? Opiates, if yes, I use more opiates to relieve this pain when it occurs. I avoid opiate withdrawal to avoid this pain. I continue to use. I no longer use opiates to avoid the pain. So we recruited over 6 months in 2015. We recruited over 685 people who inject drugs, who were daily opiate users in the previous 6 months. 307 of them had an old healed injury that's typically pain-free. So it's a population who's had a lot of physical trauma. The mean age was around 45, and 69% were male, 61% white, 34% Aboriginal. So very similar to the population I'd interviewed. And the main finding is that of the people who had a previous injury that's now pain-free, 40% had withdrawal-associated injury site pain during opiate withdrawal. And that represented 18% of the overall sample. So if you're dealing with an IV drug user, if your population is similar, then at least 40% of the people will have pain at their injury site. So it's a significant phenomenon. So we're looking, this is the prevalence. So this has been an as yet undiagnosed phenomenon. And of those, 68% said having WISP affected their opiate use behavior. 71% used more opiates to relieve, 24% avoided opiate withdrawal to avoid going into WISP, and 5% no longer used opiates to avoid WISP. Because we looked at people who had used in the last 6 months, there may be other people who years ago went off to avoid having WISP. We don't know. So that 5% could be higher in a lifetime population, but in this population, there already, just in a 6-month block, there were people who said, I stopped because I can't stand having this happen to me anymore. And when I did I did not do the multivariate analysis. It was our brilliant statisticians We looked at it, so many factors, left, right, and sideways. We looked at over about 25 factors, and it was not associated with just about anything. The only thing we could find, it was negatively associated with having chronic neuropathic pain, which was kind of opposite of what I thought might happen, but it had no association with any other kind of chronic pain or with a particular opiate or with a mental health status or with HIV status or with a stimulant drug use or anything. And in sub-analysis, we looked at that population with neuropathic pain, and it turns out that having neuropathic pain and being WIS-free, despite having an old injury, was associated with being HIV positive and taking gabapentin or non-steroidal anti-inflammatory. Sorry, that's a lot of blah, 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 blah. So what that means is that the patients who didn't get this pain at their injury site when they withdraw, they were more likely to be an HIV patient who is on gabapentin or ibuprofen already. And so it could buffer WISP, the withdrawal pain. So we now know that there's a significant prevalence of WISP among people who inject drugs, and that it affects their opiate use behavior, and that having neuropathic pain may be negatively associated with it, but we may have medication confounders. They may be on the medicines that actually do the treatment, which was actually really encouraging, that the two medications that came out in the meta-analysis are the ones that have been shown to help block this phenomenon, and it lined up with the ones that my previous patients in the other study we did said could help. So that's why I titled this talk, The Relief That Binds You. So though opiates provide relief, both emotional relief for your noradrenaline, for your trauma, and that's why it feels good, it takes your pain away initially, but it binds you to it because it starts to produce pain, and so you need more. And also you get a withdrawal syndrome, so you need to take the opiate to relieve your withdrawal syndrome. So it creates this cycle of bondage, really. Okay, I just want to acknowledge my co-workers in that setting. And also, I decided to step down from being the director of, it was at that point, the St. Paul's Hospital Gold Core Addiction Medicine Fellowship. We call it something different now. In order to do this research fellowship that I did 2 research fellowships to finish this. So I just wanted to acknowledge my supervisors in that, and the research fellowship through University of British Columbia, a clinical scholars program for family docs that I did, and then went on and did a Canadian Addiction Medicine Research Foundation fellowship that was funded by the National Institute of Drug Abuse, NIDA, in the United States to get that research done. So I just want to acknowledge that. Good, and I included some references for you on that topic. And I just wanted to hear your cases as well, to see if you've ever seen this phenomenon in your patients, or if you've ever noticed withdrawal being a barrier, or them getting more pain as they go up and needing to go up and up on their opiates. Has anybody seen any of that in your population, or think it might be at play?
I've seen it where they stop and stay away from the opiates, if it was aversive to them.
Mm-hmm.
I think it's a minority.
Mm-hmm. So what he's saying is that he's seen some patients who have such a bad experience with it, they come off of it so that they don't go through that cycle. But he thinks that's the minority, that most of them end up hooked in the cycle. Yeah.
Can I just ask about, you talking about cancer pain as opposed to non-cancer pain?
Yeah, I don't treat cancer pain usually, so I'm not the one to ask, but go ahead.
Well, just in the research, is there much stuff around this?
Yeah, see, I haven't seen literature around cancer pain. First of all, when I see cancer pain, I just avoid it. I just don't read it. Because I'm like, no, that's not my population. I don't have to read that. That's the oncologist. So to be fair, there might be something on that, an article or two that I haven't looked at, because I just automatically avoid. But in general, the population is either the addicted population, people with substance use disorders, opiate use disorders specifically, or people who have chronic non-cancer pain. The other thing to know is that there is a couple of articles now published on not just opiate withdrawal causing pain, but alcohol withdrawal causing hyperalgesia, that people can get more pain sensitive during alcohol withdrawal. And again, it may be an NMDA receptor glutamate thing during alcohol withdrawal, but it's interesting that alcohol withdrawal too can make you more pain sensitive temporarily, not just opiate withdrawal. And who knows, it may be true with other substances, it's just not tested yet. Maybe a whole phenomena during withdrawal. Yeah.
When you mentioned the reduction in the opioid-induced hyperalgesia when you take someone from a very, very high dose of opiates down to what still seems like a moderately high dose of opiate, you still get that effect if you take someone from like a moderate dose to a minimal dose, or like?
Do you get improvement in their pain? Is that what you're saying? Yeah. So that's the hope, right? It depends on what their underlying issue is. You know, there's some people who have an underlying issue that you keep grinding your joint, or you keep, there can be mechanical and physical pathology as well as sensitization in the nervous system that gets worse. And sometimes, as you take people down, I always tell them during the withdrawal phase, every time we take you down a bit, you're going to get more pain. You can get more pain sensitive, but let's just hold and wait and see if you go. So if you go slowly, like that's why in the detox setting, within a week or two, I can detoxify you and get you off and lickety-split. In the clinic where I want you to keep working out and dealing with your pain, it'll take us 6 or 7 weeks. And if it's an outpatient without all that multidisciplinary support, it can take 1 or 2 years to get somebody down on their opiate, or sometimes off. And sometimes it's that last 20 or 30% it's really hard to get them off of. And sometimes, so what if if they were on a dangerously high dose, like 800 milligram equivalent, and you can get them down to 80 milligram equivalent, that's total success. Or even 20% a year, that's great. Wave your flag. Yeah. So, yeah.
I'm just thinking back to the slide. I might have the numbers wrong because this is from the beginning, but you said like 12% of people find opiates effective.
Oh, sorry. Yeah, so this was Dr. Bussey had said that 1 in 12 actually are opiate responsive. It was a lecture I lectured, he and I both lectured for this law group in Vancouver about a month and a half ago. And I heard that I thought that was interesting. The literature that I personally have read, a lot of the stuff that Jane Ballantyne has done shows that only about 1 in 4 people are opiate responsive.
So I guess 25%, if up to 35% become addicted, it seems to me that we're liable to do more harm than good by using these medications at any point in time. So, I don't see a lot of the addicted patients that you see, but I see a lot of my back hurts and I'm not taking anything, and what can I do for it?
Yeah.
A lot of the, if I stop taking that, Advil doesn't work, Tylenol doesn't work, swimming doesn't work, stretching doesn't work.
Yeah.
Do something.
Right.
And so now I'm like, well, I don't know what.
Yeah. And it would be great if just giving them an opiate would fix all that. It's just that the literature is that usually it won't. However, if the person has no other risk factors and they have a neuropathic pain condition, supposedly, or a mechanical condition, and low-dose opiate episodically, and they don't escalate, and they use it for improvement of function. They don't use it so they can lie on the couch more comfortably, but they use it when they have to do something very physical that's outside of the normal range of their behavior, or, sometimes you can use low-dose opiates in a reasonable therapeutic way, but we just have to be mindful of all these pitfalls that we didn't know about before. I have patients who are on opiates, and even, methadone patients who didn't get hyperalgesic in terms of more pain disorders that I saw that have been using it for years and years. But we have to be more cautious, like you're pointing out. We have to be more cautious. Yeah, Sharon?
I hope this is all really true research, because
Oh, I didn't make it up, if that's what you mean. You're hoping it's true, but
Saying that there's research going on in the area where people are coming in like on really, really high dose opioids for years, and they're interested in doing something about it. So that's
yeah,
there. But and saying, we'll take you down actually the pain you're feeling while you're on 1,000 milligrams, it might get better. And
yeah,
I don't know if you have the counseling tools for that, but I'm just saying because this is happening. People are noticing this, and let's try it.
yeah,
And I've had a few successful ones, which we tapered one person over 2 years.
yeah,
1,000 grams, and very slowly and completely off now. They still have their dependency, but which was at the same time anyway.
right.
And it's been successful.
Yeah, so Sharon's saying she tapered somebody off over 2 years, 1 year?
2 years, 1,200
Over 2 years, he was on over 1,200 milligrams and slowly tapered him off. And how's he doing? She.
well,
Two of them.
well, let's say actually not there is no difference in their pain.
No difference in their pain. And I hear this all the time, and people wake up and stuff. But, if you did a cold Pressor test to find out about hyperalgesia, which is a response to pain, that might be different. But yeah, patients often have just built tolerance over time, and you're... Mm-hmm.
I just had a question about usually when patients are coming on these, they got the fentanyl patches on and whatnot. So they're not just on that; they are also have other substances problems. Plus, usually to manage the pain, they're on the other cocktails that they might use, like the anticonvulsants and SNRIs and all that.
Right.
How does that impact that?
Well, there's some of it that might actually be helpful, like when they're on a gabapentinoid and they're on an NSAID, may actually be helpful while they're tapering, So there's that part of it. Certainly we do see people who get flares or rebounds of pain if they come off a neuromodulator, so gabapentin or pregabalin, Lyrica fast, or stop it abruptly, which we never advise people do, right, to taper down. But the whole drug cocktail, I have a couple of case presentations I can do on the whole drug cocktail situation, if you want to see some of those. I don't know. We have 50 more minutes. Do you want to see some drug cocktail cases? Okay. I have to go to another slide. Are you guys doing okay? We thought this would be a crowd of only physicians, so I apologize profusely to non-physicians in the crowd who maybe this is a little hyper neurophysiology geeky kind of for you. I'm sorry, I apologize. But I'll show you some cases. Okay, so here's a 47-year-old married at-home father. Degree in psychology, no family history of substance use disorder. At age 19, he had an L4-5 discectomy for a prolapse disc. Post-op, he was given Tylenol 3s, which he promptly mixed with alcohol to get high because he was 19 and felt like it, he and his friends. So 10 years, he was fine. His T3 prescription stopped. He went running around. He was fine from his back. But 10 years later, he got a recurrent disc herniation. Now 29, he had surgery, and initially he was successful, and then he had increasing low back pain over the next year, and over many years from then to the age of 47, he was seen by lots of different docs, and his opiates slowly escalated, and I'll show you that pattern. This is what he was on by his GP initially, trying a variety of different medications, and then giving him hydromorphone, short-acting, up to 80 milligrams a day. And the client was running out early and crushing and smoking them, but he said that's the only way he could get pain control, because you get that spike. That's not good analgesia when you're just having a temporary spike. When someone starts to crush and smoke, that's a big red flag for addiction, even though they say it's for pain management. But that's their lived experience, is that's the only time they're out of pain, right? But that's, anyway, problematic. He was on fluoxetine 60, lorazepam 4 milligrams at night, and the pain was unmanageable, so he got referred to a pain clinic that will go unnamed, not ours. So all these meds were altered over many years, but when we saw him at the Orchard to detoxify him voluntarily, this is what he was on. Fentanyl patch, 150 microgram per hour total, so 150 patch, changed every 2 instead of every 3 days as prescribed, plus fentanyl solution liquid, 100 microgram 2 ml vials. He was doing 3 to 5 vials a day, and he was also doing a fentanyl film, 600 micrograms twice a day for 1,200 micrograms per day. Tramadol, 50 milligrams, 2 of them twice a day, so 6 that should have been 3 twice a day. So he had 6 tabs a day for 300 milligrams. Methadone tablets, because he was a pain patient, not an addiction patient apparently. 60 milligrams twice a day, so 120 milligrams of methadone. Hydromorphone, short-acting, 80 milligrams per day. So he was snorting that just to try to get some pain relief before he'd go for his runs. And then morphine equivalent dose was, if you're super conservative converting that would be about 1,830 milligrams. If you're not, it would be probably over, closer to 3,000 milligram equivalent. But he was also on fluoxetine, on some more diazepam, but still using the lorazepam. He was on a decongestant, Sudafed, because he'd get kind of clogged up and sleepy feeling. So he'd take 2 tabs a day to keep him up, and he was taking caffeine pills and energy drinks to keep himself awake in all this. And he still felt pain. However, otherwise he felt great. And his function was up. This was the tricky bit, because we always say, is there a change in function? That's where we prescribe or not. He was running triathlons. So he felt great. He was a stay-at-home dad, and his wife was working. But others were seeing sedation in him that he did not notice himself. But what brought him into the orchard was not worries of addiction by his pain team prescribing this or his family physician, but it was because his wife's healthcare plan stopped wanting to pay $3,000 a week for all this medication. They cut him off cold turkey. So he came whimpering in, I don't want to go off cold turkey. Anyway, it was voluntary admission for medically supervised residential treatment, which we did. We have the whole gamut of stuff we expose him to. So we kept his methadone and fluoxetine the same. We stopped the tramadol, stopped all the fentanyl after a 2-day taper, added quetiapine, and we didn't see any withdrawal. How can that be? What are the options here? Why is there no withdrawal? We just cut his opiate dose in half, basically. He could have been diverting. We followed this guy for over a year. There was no evidence of diverting. His wife had seen him take his pills, so we don't think he was diverting. But yeah, he could have been diverting somehow in a way no one ever knew. His receptors were so saturated that the other stuff was just kind of added boosting sedation. It really wasn't doing anything to his opiate receptors. So we could just, and we do that a lot in the treatment center. Here, instead of 5 years of tapering, like right down, get him down. Yeah. And then we tapered his methadone over 3 weeks to 5 milligrams, 3 times a day. And then we held his dose, and then we switched him over to Suboxone and titrated him to effect to 6 milligrams. And Bob's your uncle. Follow-up 12 months, Suboxone conversion. He's on buprenorphine and naloxone. Suboxone still, 6 milligrams. Fluoxetine 60, quetiapine 125 at night, and tapering that. He'd attended 12-step daily, had a sponsor. No relapses or slips. His wife was fed up with this guy. She was gone. But he didn't even relapse when she left. And no more pain issues. Every time he'd go below 6 milligrams of Suboxone, he felt back pain. But whenever he came up above, he had none. And he felt clear and fine. So it's pretty phenomenal. Yeah. He's a real person, I treated him. I'm not saying every patient responds that well, that would be fantasy. But I'm just giving you an example of what can happen. And I'll show you one that is an interesting example. Includes some opiate, but the opiate thing isn't the big issue here. Anyway, I'll just tell you about Emma. She was a care aide and had a torn rotator cuff and had come in. And she'd been a woman who really for decades had not slept well. And so her family physician had started her and put her on various medications, and she'd seen a psychiatrist who'd put her on meds, and then she'd seen the new psychiatrist when the old psychiatrist retired, who put her on more meds. So she ended up on over 1,000 milligrams of chloral hydrate to sleep, as well as amitriptyline, about 150 milligrams, and Zopiclone, 14 milligrams, and temazepam, 30 milligrams. And she was still not sleeping. She was sleeping 2 hours a night. But every time you saw her as a clinician, she would yell about not sleeping. She was also on Tylenol 3s and Tramadol. And because she was sleepy, they were giving her a little bit of Ritalin to stay awake during the day with all of that. And then she was taking muscle relaxants because she was tense, her muscles hurt, so she was on Flexeril. So she came in on all this, and everybody had been well-meaning who had started each of these things, but the gal had a rotator cuff tear. Like, seriously. So I called her clinicians because I didn't want to detox her and then have her clinicians put her back on it. That's not effective. So I got the permission, and all the docs involved were like, yes, please do something. Because Emma, she's about 5'1" and weighed close to 200 pounds and was just a force of nature. She was hilarious. And just like, hello, she'd yell at you across the room, I'm not sleeping. She used to yell at our pharmacist across all of her patients, I didn't sleep at all last night. Anyway, so she would distress everyone she would see because her pain and her sleeplessness was now your issue that you had to solve. So everybody tried to solve it with their prescription and give her something. So she got all this incredible layering of stuff. So we just one by one, over our program, just detox her from everything. And she said, my God, I feel like I'm coming alive. But yeah, and the history had been, if you dig down, you go for the trauma history or whatever, she had been in a very abusive relationship with her husband, had developed some binge drinking to the point where she couldn't control things, and her children had to go live with her sister. They weren't apprehended, but she tucked her kids away while she was with this abusive spouse, and then she finally got free of him. And then over a few months got off of alcohol and then got her kids back, and then has been working like a dog ever since. Right? Never processed anything, never did any work, never, and then just worked and worked and worked, and then the rotator cuff gave out. And then all these meds, the docs had just added and added and added. It's just like iatrogenic nightmare to this whole situation. So we see that a lot, that kind of, just well-meaning but additive. If something doesn't work, instead of adding, take it away. But the patients are so scared for you to take it away. They don't want you to take anything away because it might be working, especially an opiate. It's not working, doc, give me more. If it's not working, we're going to take you off. Sometimes I say things like, we've tried every single category of medication with you, usually one or two things from each of the kind of 9 categories of pain medicine, and nothing's worked. Your medication unresponsive. Your medication unresponsive. It horrifies them when you say that. But I say that, even in someone who's medication responsive, it can only bring your pain down 1 or 2 points on a 10-point scale. Even the strongest opiate we have, not for acute pain, not the first time you get it, but for chronic pain management, will only going to bring you down 1 or 2 points on a 10-point scale. Is it worth it to you to go on this med, knowing all these potential side effects, knowing long-term only going to be able to bring your pain down 1 or 2 points, and we may increase your pain long-term? So you have to have that kind of balanced conversation with folks. And then you can miss things too. So sometimes someone comes to you and they're on an opiate or using street drugs, and really there's an underlying medical condition that's gone unseen. So the reason I got into addiction medicine is I was on a palliative care rotation as a resident in family medicine, and I was called to a home to see a young woman, Lisa. Her family gave me permission to use her first name. She was 29, had long blonde hair like me. I was 30 years old, so I really identified. She had one brother and a single mom like my family. So there I was staring into someone I could relate to very much. So she'd been having abdominal pain and going to emerge for the last year. She'd been 9 times to the emergency room in Toronto, where I was. And each time the nurse had taken her blood pressure and taken a history and found out that she used some heroin. And the doctor came in and said, heroin withdrawal causes abdominal pain, and gave her some Tylenol 3s and sent her home with her mom. She'd go with her mom every time. And on the 9th time, a year later, one of the emerge docs thought, maybe I should examine her abdomen. What the hell? So her liver was in her pelvis at that point, because what they found when they biopsied her liver is that she actually had adenocarcinoma of the bowel cancer, that had metastasized to her liver. And she was now stage 4. She was palliative, inoperable. So they sent her home to die. And so I was sent in to help her get pain control through the night, the day that she was sent home from hospital 3 days after she'd been first gone in, and a day after she'd been diagnosed and had a bleed from the biopsy. So we tried to control her overnight with some morphine, and this was unsuccessful. So she went into hospital the next day, and the nurses pushed her under with morphine, and she died. So it was a very tragic situation. Her family was incredibly distressed, as one can imagine. And who knows, the first time she presented to emerge, if the doc had actually seen her as a full person, instead of addict, but seen, oh, this is a young woman, she may have an addictive disorder, she's using heroin, but she has something else. Or he may have found, actually, the pain preceded the use of heroin. Her friends were helping her treat her abdomen pain because she was complaining, if they'd taken a careful history. And if they'd taken another careful history of family history, they'd have found out her dad died of adenocarcinoma of the bowel at age 34. But that was missed because she wasn't seen because of her addiction. And so that really influenced my kind of whole career path, because I was like, how could you not see this person? Like I could see her in front of me. She was just so amazing. And her life was gone like that. And so I thought, wow, something's off in our profession. And why is that? It's because people are exhausted and they don't feel like they can treat an addiction. I think if you find an addiction, it's like, great, I've made a diagnosis. It's like, great, I figured out why you've been so tired. You got diabetes. Jeez, you're peeing sugar. I figured that out. I'm smart. So now it's like, wow, you figure out somebody has an addiction? You should be like, great, it's a treatable disorder. Isn't that great? Aren't you smart? Yeah. And you can give hope to your patients. It's a treatable disorder. It may not be curable in the same way. It's treatable. And yes, there'll be relapses. Yes, there'll be things along the way, but it's a treatable disorder. So if Lisa had somebody who had seen her originally, maybe something else would have happened. Maybe she could have lived, or maybe she would have at least had a year where she could have gotten ready to die with a bit more grace than what happened, and her family could have prepared. Like my patient Barry, who came in, he's a retired bank robber. 67-year-old retired bank robber, absolutely delightful fellow. And he had abdominal pain when he came to see me, and he was using heroin, and he wanted to get off heroin and wanted me to help him, but I didn't like the fact he had abdominal pain, so we did a little investigation. I found out that he actually had stomach cancer that had eroded into his liver. And so we went, it was not treatable as well. But we got him diagnosed early, got a little bit of symptomatic treatment for him. And so he had about 6 months before he died. And at least he had that grace of knowing what was going on, being treated with dignity. And he married his longtime girlfriend, finally did that, tied the knot. They got married in Stanley Park. And he contacted family members that he hadn't seen in years and years and years in order to make contact again. And he had a lot of resolution. He still drank, and they let you drink on the palliative care ward in St. Paul. So I went and seen him on the palliative care ward, held his hand the night before he died. Just, that ethereal look people get when they've kind of auto-absorbed all their flesh and they're thin and looking over the other edge, of the precipice. Yeah, he was just tears rolling down his face. I love you, Dr. Rieb. I love you too, Barry. Have a good trip. We'll see you on the other side. Yeah. Yeah. I think that's a good place to stop, hey? Okay. Thanks for being so attentive. I hope it was useful for you. Yeah.